I know you can help us record, sir.
Angama.
Thank you. Okay. Before I
Okay, so good evening, everyone. So I'll start from 141, and then we'll take others as we need them. Okay, I hope I'm audible. Okay, question 141. All of the following statements regarding the epidemiology of hypertension are true, except, so we're looking for the false answer. So number one, A says, among individuals age 60 years or older, average systolic blood pressure is higher in women. Diastolic blood pressure increases steadily with age throughout life. Okay, let's go back to A. Among individuals age 60 years or older, average systolic blood pressure is higher in women. Okay, yes, that will be true. Before the age of 60, it said blood pressure is said to be higher in men, but after age 60, it is actually much higher in women, the systolic blood pressure. But before age 60, it is much more in men. Then after 60, women take over. So that's a true statement. So that's not what we're looking for. Then B says diastolic blood pressure increases steadily with age throughout life. That is not true. We know that diastolic blood pressure increases, but after around 55, 60 years of age, we notice that there's a decrease in the diastolic blood pressure. And that also adds to the widened pulse pressure we have with in older age group. Apart from the fact that, okay, they have atherosclerosis where systolic blood pressure is much higher in them. You now have a reduction in diastolic blood pressure, and that will now widen the pulse pressure. So option B is actually false. So, and that's the answer, but let's look at the others. Hypertension prevalence is lower in Mexican Americans than non-Hispanic whites. And these ones are studies among the US and all those places. So that's true. They found out that the prevalence of hypertension is higher in non-Hispanic Blacks, followed by non-Hispanic whites, and then Mexican Americans, the natives. So it's the Blacks, then the whites, then the natives. So if we now say hypertension prevalence is lower in Mexican Americans than non-Hispanic whites, that's the true statement. So option D says in industrialized nations, blood pressure increases steadily during the first 2 decades of life. That has been shown to be true as well. Of course, we don't have that kind of data here. We're not industrialized, but in the industrialized nations, that's what they have observed in their population. And then the prevalence of hypertension is approximately 30% as well in the US. That is true. For Nigeria, the prevalence is put to about 25 to 40. It's very high as well. So as we know, hypertension is #1 driver for cardiovascular disease generally. And it's about 30% in their own US population. In our own is a wide range between 25 and 40. Okay, so the answer to 141 is B, that yes, diastolic blood pressure increases steadily with age, but it is not throughout life. At some point around 55, 60, it actually begins to decrease, and that contributes to the wide pulse pressure that they can have. Thank you. Any additional comments? Okay, if there's none, I move on now to 142. 142 is straightforward. Disease of which organ is the most common cause of mortality in hypertensive patients? It's actually the heart, right? So it's the heart. Cardiovascular disease, the leading cause of death and complications in hypertensive patients. The commonest cause of mortality is the heart, followed by the brain when we have strokes. Okay, so sometimes we may not relate directly to this because of how well we practice, but this is an American brand. It's real. They are really seeing it because sometimes we may say, oh, we're seeing more and more mortality with strokes and all that, but the heart is actually the organ that is most implicated in most mortality in hypertensive patients. So we have the heart, then the brain, then the kidneys, liver, and lungs much lower. Okay, do I move on?
Okay, let me just contribute here a bit. Thank you, Chief Etubi.
Thank you.
If we look at WHO data on hypertension and cardiovascular diseases globally, the Afro region, that's in Africa, has the highest burden of hypertension, like you mentioned. So our burden might even be higher. But the two main killers as complication of hypertension are cardiac diseases and stroke. Cardiac mainly, ischemic heart disease and stroke. So generally in the West or in predominantly Caucasian populations, ischemic heart disease is the number one killer, while in black populations, stroke is. So this is actually like reproducible elsewhere. It's not just Nigeria. Generally in Africans, stroke seems to be the more, like, as opposed to ischemic heart disease, is the more common manifestation. And then the cardiac diseases as complications of hypertension that lead to mortality. Of course, ischemic heart disease is right up there, but also hypertensive heart disease causing heart failure, arrhythmias, and even microvascular, like microvascular ischemia is also somewhat related to hypertension, in addition to the epicardial, like main coronary artery disease that we know. Thank you.
Thank you very much. That's very helpful. Thank you. Any other, or do we move on? Okay, so we move on to 143. 143 reads, if a 28-year-old woman has hypertension that is difficult to control, she was diagnosed at age 26, so she's been hypertensive for 2 years. It's difficult to control. Since that time, she has been on increasing amounts of medications. Her current regimen consists of labetalol 1,000 milligrams twice a day, lisinopril 40 milligram daily, clonidine 0.1 milligram BD, and then amlodipine 5 milligram daily. So on physical examination, she appears to be without distress. Blood pressure is 16800 millimeter mercury, and her heart rate is 84 beats per minute. Cardiac examination is unremarkable, without rubs, gallops, or murmurs. She has good peripheral forces and no edema. Her physical appearance does not reveal any hirsutism, fat maldistribution, or abnormalities of genitalia. So laboratory studies reveal a potassium of 2.8 milliequivalent per deciliter, a serum bicarbonate of 32. Fasting blood glucose is 114 milligram per dl. So what is the most likely diagnosis? Is it congenital adrenal hyperplasia? Is it fibromuscular dysplasia, Cushing syndrome, Cohen's syndrome, and or pheochromocytoma? So for this patient, one will see that it's a young person, 28, and then diagnosis was made even earlier at 26. also been hypertensive for like 2 years. And then this is a person, young age with difficult to treat hypertension. She's not had a good control. Blood pressure is still high up there, 160/800. But the question has lots of information. One, she's without distress. Then we see that there's nothing remarkable in a cardiovascular system exam. And then physically, no hirsutism. All that will be ruling out, okay, some things we expect that are part of the options here, like fat maldistribution, which is what we would see in Cushing syndrome, and abnormalities in genitalia. We can have that in congenital adrenal hyperplasia, in which there's distortion in their growths, and then they can have abnormalities in the genitalia, even the menstrual cycle, all that, but we don't have any information relating to that. And then from what we have in this question, there's nothing really on physical appearance. So that would rule a number of the options here. And then we don't have a history to suggest something episodic, like episodic headaches, sweating, or palpitation, or episodic rise in blood pressure. So if we had something like that, we might be looking at pheochromocytoma, but for her age, so we're looking at a secondary cause of hypertension. But if we look at the potassium level, we see that it is low, 2.8. Then we have a slightly increased bicarbonate, which should be metabolic alkalosis. And then blood sugar is even normal, less than 126, which is less than 7. So fasting is fine. No abnormality in genitalia, no hirsutism, no fat maldistribution. So it rules out many of these other differentials. And that leaves us with option D, which is Crohn's syndrome. So if we have a young person with secondary hypertension, difficult to treat, something we can think about could be primary hyperaldosteronism, which is Crohn's syndrome. And then the investigations we have are supportive. So in Crohn's syndrome, we have hypokalemia, hypernatremia, and then we have metabolic alkalosis. So that makes option B the answer to 143. Any addition? Okay. So I move on to 144 now. Okay, so 144 is still on, is a continuation from 143. Excuse me. It says, what is the best way to diagnose the disease in the patient described in question V143? Since it's Crohn's syndrome, the best way to diagnose Crohn's syndrome is actually checking the plasma aldosterone renin ratio. So that's pretty straightforward. And because it's primary hyperaldosteronism, so we expect that the ratio will tilt much more in favor aldosterone. So it can be as high as 30 to 50 times above in the ratio. So if we do renal vein renin levels, that wouldn't help. If you're doing 24-hour urinary collection of metanephrines, that would be when we're thinking of possibility of pheochromocytoma, which is not in this case. And then MRI of the renal arteries would not also help here. We're not thinking of a stenosis or an obstruction. And 24-hour urinary collection of cortisol when we're trying to rule out Cushing's, but all that is not helpful since we know we have these as Crohn's syndrome. So what to do next is actually to check the plasma aldosterone renin ratio. Is there any contribution or comment? Okay, so I'm moving on. Sorry, can I just get feedback? My network is funny. Let me be sure.
We can hear you. We can hear you.
Okay, thank you. 145, Mr. Wilkins is a 65-year-old aeronautic engineer who has never been to the doctor and he takes no medications. He's brought to the emergency department by his wife for worsening headaches over the last day and confusion starting about an hour ago. His blood pressure on presentation is 230 over 140 millimeter mercury, heart rate 90 beats per minute. Arterial oxygen saturation is 95%. On examination, is moving all extremities equally, and there was no obvious deficit in his cranial nerve function, but he is clearly delirious. Cardiac examination reveals an enlarged.
Is blocked.
Uh, hello?
Sorry for the interruption. You can continue, please.
Okay. So he's was moving all limbs equally. There was no obvious cranial nerve deficits. There was no cranial nerve deficits. He's delirious. Cardiac examination reveals an enlarged and forceful PMI. I think that's like point of maximum impulse. And S4 gallop. Okay, so the atrium is forcefully contracting against the ventricle. So his lungs are clear to auscultation. So in the lab studies, what do we have? We have 2.4 milligram per DL of creatinine. That's already elevated. There are 2 pluses of proteinuria and hematuria as well. And then the hematocrit was 32%, but the platelets were normal. You examine his peripheral blood smear and note schistocytes. Emergent brain MRI shows old microvascular changes, but there's no acute infarct or hemorrhage. Regarding his blood pressure management, which of the following would be the most reasonable therapeutic and course? So this is already a hypertensive emergency. Actually, this man has like malignant hypertension. We don't have records of his pre-morbid states, but his blood pressure 230, 140, and then he was already delirious. Then we can see that he has hematuria, he has mild anemia, and then there are schistocytes in the blood smear, and then he's creatinine also, suggestive that he's already having some renal dysfunction. So the fact that the man had not been to the doctor before taking any medication might not rule out that he might have had background hypertension. Okay, so especially because most times malignant hypertension occurs in the setting of those already hypertensive. And then another thing to look at is that he already has an S4, which means that there's some poor ventricular compliance to the contraction of the atrium, because we hear an S4 when the atrium tries to contract forcefully against a non-compliant ventricle. Okay, so, and in this type of setting, we would like to, it's an emergency, so you want to bring the blood pressure down within minutes to hours. And the best way to do this would be intravenously, and then and not to go orally or to use drugs that would that have erratic blood pressure reduction. So if we look at so they're saying regarding his blood pressure management, which of the following would be the most reasonable therapeutic course? Is it to give 0.1 milligram of clonidine orally, that wouldn't be what we would do. We also will not give 20 milligram of lisinopril for this type of patient who is delirious with all these target organ or hypertension organ-mediated damages already ongoing. But option C looks like what we would do. We would give him IV labetalol, okay, 20 milligram, and initiation of a continuous parenteral drip, because we know that labetalol is short-acting. We give the IV dose and we don't have a continuous parenteral drip, we would have a rebound subsequently. So yes, we would give IV labetalol, we initiate a continuous parenteral drip, and then we want to maintain the arterial pressure at that level in the first hour. Because what you want to achieve is, if we check the sorry, I didn't do that, but if we check the mean arterial pressure to be somewhere around 230 minus 140, 1/3 of that plus 140. So but the aim is to target reduction of about 25% from minutes to hours, because we don't want to rapidly drop the blood pressure, okay? Like using immediate release oral nifedipines and all that. You don't want to do that because the set point is likely high for the patient. Okay, so and we know that cerebral perfusion pressure is closely linked to the mean arterial pressure. So it's to bring the blood pressure down within minutes to hours, and then the target will be a 25% reduction in the mean arterial blood pressure. So when we do that, that would be a better way to manage the patient. So in option E, emergent plasma pheresis, we will not need to do plasma pheresis here, because even though we are seeing schistocytes, the platelets are normal. So I don't think there's any reason or room for that to be done in this patient. So the most appropriate answer is option C. Option C. Thank you.
Continue, sir.
Okay, thank you. So we'll go to 146. 146 says, which of the following statements regarding the physiology of renal perfusion is true? Physiology of renal perfusion. So which of it is true? And so A says, due to tight precapillary regulation, the glomerular capillary endothelium is relatively shielded from pressure injury. Okay, that's not true. So we know that whenever we have excess pressure, that can affect even inflammation, oxidative stress, just like they affect other vascular territories. They are capable of affecting the glomerular capillaries as well. So that option is not true. Option B says renal cortical flow is less than renal medullary blood flow, and coupled with the high metabolic needs of the renal cortex, this leaves the region bordering on hypoxemia. If we recall that the supply of the kidney is quite complex, where you have the cortex and then the medulla. So the cortex actually has very rich supply. That's one. And then two, the cortex is said to have more oxygen supply than the medulla. So if you look at the option that talks about the renal cortex is less than the renal medulla blood flow, that's not true. And then coupled with high metabolic needs in the renal cortex leaves the region. No, you have more of relative hypoxia more in the medulla than you have at the cortex. So that makes that answer false. So we're still looking for what is true. Option C says renal perfusion is tightly regulated to the metabolic needs of the kidneys. the kidney does not only respond to its metabolic needs, okay? So metabolic needs of other organs, okay, also drives or dictates or participate in how the kidneys respond. So it's not just to its need. Then option D says urinary albumin excretion. Urinary albumin excretion is predictive of systemic atherosclerotic events and can present years in advance of clinical atherosclerotic disease. Okay, let me go to E. E says venous blood returning from the renal cortex has lower oxygen content than venous blood returning from the medulla. Okay, we've talked about this. That is false. So I think the most appropriate answer here is the fact that, okay, when we do urinary albumin excretion, UAE, it is actually a predictive test. They said it can predict atherosclerosis like in 10 years' time. So it's a futuristic test that can be done. So that is the true answer there. That urinary albumin excretion is predictive of systemic atherosclerotic events and can present years in advance of clinical atherosclerotic disease. Thank you. Is any comments? I'll move on.
Dr. Ruki, any comment?
Okay. No problem. Thank
Okay, thank you. I think you should
All
continue.
right, thank you. 147. Which of the following statements regarding renal artery stenosis is true?
Sorry, before you read the option, I don't know if there's any need to like define microalbuminuria, just to remember we are all comfortable with it.
I think since you've mentioned it, that we can actually do that to remind
Since
ourselves.
Okay.
yes, since that was the correct option. So like the option mentioned that microalbuminuria can predict, atherosclerotic cardiovascular disease long before it happens. So like in patients with diabetes, it's one of the markers of prognosis, and regular urinary dipstick is unable to detect it because it's below the concentrations that the test can pick. So microalbuminuria is defined as urinary albumin excretion of 30 to, so some would quote 30 to 300, some would quote 30 to 299, but 300 is the upper limit of albumin excreted in 24 hours. So we're doing 24-hour urinary collection is 30 to 300 or 299. Because macro starts from 300 and above. So in 24 hours, or if we're using urinary albumin creatinine ratio, is the same range, 30 to 299 milligram of albumin per gram of creatinine. Some labs will use microgram per milligram. Either way, it's the difference in unit, microgram to milligram or milligram to gram. So like the difference is like multiples of 1,000. Or the last one, I think spot urine concentration, which is less used. But at least if we remember the spot urine, albumin creatinine ratio, or 24-hour urinary collection. So the range is similar. Some labs or some references would put a different ranges for males and females, but I think generally this is the range that is used. So some labs would put for the males a bit lower, 20 instead of 30 for the albumin creatinine ratio. Yes, for albumin creatinine ratio starting from 20. In case,
Thank you very much.
Thank you, Dr. Ruki. You can continue, Dr. Etsobe.
Okay, thank you. So 147, which of the following regarding renal artery stenosis is true? We're looking for the option that is true. And then in renal artery stenosis, there's a narrowing. And it can be unilateral or bilateral, can have both narrowed. And we know it's a major cause of hypertension and difficult to manage too. And the major cause is usually fibromuscular dysplasia, okay, or atherosclerosis. So either atherosclerosis of the renal vessels or fibromuscular dysplasia often cause it. And usually they have elevated blood pressure that is difficult to control. And then on auscultation, we can hear the renal brew when we auscultate. And one of the early signs we see in them, or the early findings, is that the renin levels should be elevated, because with the stenosis, there's actually some reduced or hypoperfusion, which would stimulate renin release. So one of the earliest things that is found in them is the elevated renin levels in them. Then most times the aim for management for them is usually either a stenting or a renal angioplasty, just to open up and allow more perfusion of the kidneys. So, and then before we do an MRA or a renal angioplasty, of course, there are things that can be done, like doing their ultrasound scan. That can also help. And usually in ultrasound, because of how narrowed it is, by the time you're looking at the Doppler ultrasound wave, it is usually very high. Okay, the velocity is high, most times more than 200 cm per second. So just a little on renal artery stenosis. And then in this question, we're looking at what is true. So A says an abnormally reduced renal artery flow velocity by Doppler ultrasound is predictive of hemodynamic significant stenosis. That will not be true. What we expect is that there'll be an increase. Okay, there'll be an increase in the renal blood flow, the velocity, because of the narrowing. Okay, and then even when there is, it does not really tell most of the hemodynamic effects in them. So option B says early in the course of renal artery stenosis, elevated systemic renin levels are typical. That is true because, like we said, because of the hypoperfusion that comes up early with them. So they have elevated renin levels. Okay, so and then in the general population, the presence of fibromuscular dysplasia is rare, less than 1% prevalence. Okay, the prevalence is put to about less than 5 though, but it's more than 1. More than 1, but it's less than 5. It's not so common, but it's not as rare as less than 1. That's what makes it false. Then the levels of renin activity observed in renal artery stenosis are predictive of response to medical therapy. That is not true. Even though we know that the renin levels and the activity, they are elevated, okay, when we have reduced, or when we have renal stenosis, but it does not predict response to therapy. So the most appropriate, or which is true here, that which is true is option B, which says early in the course of renal artery stenosis, elevated systemic renin levels are typical. So I'll move on now to 148. A 75-year-old man, he underwent diagnostic coronary angiogram after an abnormal stress test. Sour. So arterial access was obtained easily in the right femoral artery. And the angiography was completed with 35 mils of iodinated contrast dye. Fortunately, no significant coronary stenosis was noted. 7 days later, the man presents to the emergency department with abdominal pain and nausea. He reports that his urine output has been poor recently. Examination reveals a slight fever. It's a slight, this is fever, 38.3, and libido reticularis on the lower limb extremities. Laboratory studies show creatinine 2.7, previously was 1.1, white blood cell 10,500. 21% of eosinophils, and an ESR of 92 millimeter in the first hour. What is the most likely diagnosis? Okay, so this is a patient that had coronary angiogram. Before then, he was likely fine. And then after he had the procedure, and then even during the procedure, they said there was no significant coronary stenosis in him. Okay, but he already had an abnormal stress test. That was what prompted the coronary angiogram. And then the contrast that was used, the iodine contrast dye, he had the procedure. So it was just 7 days later. Okay, 7 days later, then he now had abdominal pain and nausea. Then he had reduction in his urine output. He had a fever, libido reticularis. He had azotemia, you can see creatinine 2.7. He had white blood, elevated white cells, just slight though. But there was new eosinophilia and then the ESR. So we're looking at the most likely diagnosis. So A says acute interstitial nephritis. We won't be thinking of acute interstitial nephritis because one, we do not have any evidence that there was a recent change or any medication. We're not told, about any change or any medication given to this patient. So we won't be thinking of acute interstitial nephritis. So, and then apart from the fact that he had eosinophilia, so other things, we won't think about acute interstitial nephritis. Or if we think of arterioembolic renal disease, you can see that, okay, I'll come back to that. Then in Church-Strauss syndrome, we know that in Church-Strauss syndrome is a middle vessel vasculitis, small to middle vessel vasculitis. Of course, they have associated renal dysfunction, eosinophilia, but most of the patients have history of atopy, and then they have background asthma as well. We don't have any history that would suggest that in this patient. Then for option D, talking about contrast induced nephropathy, which is a possibility here because of the iodine dye which he had. And some patients can have contrast-induced nephropathy from procedure. However, contrast-induced nephropathy is not usually associated with fever, and then the elevated ESR as well, or the eosinophilia, or even the libido reticularis, which this patient has. Okay, so the most likely option looks like an arterioembolic renal disease. And then if you look at the duration when this occurred on the 7 days. Most of these arterioembolic renal disease, the condition usually occurs after a procedure, and then most times within 14 days. Okay, and then the typical features they can have is what has been painted in this patient. The eosinophilia, the libido reticularis, the fever, the renal impairment that this patient has. So the answer is option B, or 148. Thank you.
Okay, if I can jump in here.
Yeah, please.
Remember the, sorry, Adeanju, you want to speak?
No, I was about calling you that you could come up.
Oh, the backup, but your solid plan. All right. If we remember the general medicine question, that there was an MI patient who had, yes, he had CT coronary angio. That was what was the question, not invasive. But then some of the, facilitators thought it was, mentioned that the exam, I think the right answer they wanted was atheroembolic disease. Well, I met others who went for the exam who said it was actually contrast-induced nephropathy. Either way, the two of them can be close differentials of each other because they would frequently result after a procedure. But for the atherembolic, it's usually invasive, invasive angiogram, where catheters have been passed through vessels that have atherosclerotic plaques, and part of it is dislodged. But apart from invasive endovascular invasive procedures, turns out even thrombolysis, because imagine a plaque that the surface has ulcerated and a thrombus has formed. By the time we thrombolyze, that ulcerated surface is still there, and we could have embolization of some of the contents. So even thrombolysis and high dose anticoagulation are some of the less common causes. So meaning it could actually occur without having had that endovascular procedure. But most of the questions, part of what will give it away would be the endovascular procedure. So I happen to have come across a table that tried to differentiate the two. That is contrast-induced nephropathy, which this patient could still have because he had contrast. But of course, this picture painted was clearly pointing towards the atherosclerotic disease with the features that Chief Etubi mentioned. But let me just try to, I will post the table on the group. But one of the main differences is even the time frame. Contrast-induced nephropathy would usually occur earlier after. So like within 48 to 72 hours after the procedure, while like Chief Etubi mentioned, for cholesterol embolization or atherosclerotic disease, it's usually like within 14 days. So a week, 1 to 2 weeks. Subacute, it could even occur months after, several weeks or months after, but hardly occurring less than 1 week. While contrast-induced nephropathy would occur within the first 48 to 72 hours. Then one other difference would be the protein findings. In contrast-induced nephropathy, the urinalysis is usually bland, except if they have progressed to acute tubular necrosis, where we find granular casts. But it's usually bland. While in atherosclerotic disease, it may be bland, but they could have proteinuria. So proteinuria is one of the findings. And contrast-induced nephropathy, most of them resolve without needing renal replacement therapy. But atherosclerotic disease, a good number would present to frank renal failure and need renal replacement therapy, typically dialysis. So I'll just post this table in the group. Thank you.
Thank you very much, Ruki. Thanks. That's very helpful. So is there any other, or do we move up?
Please,
Okay.
let's move on. We have a long way to go. Thank you.
149. I'm rounding up. 149. In which of the following patients who present to the emergency department reporting acute dyspnea would a positive D-dimer result prompt additional testing for pulmonary embolism? Okay, is he a 24-year-old woman who is 32 weeks pregnant? A 48-year-old man with no past medical history who presents with calf pain following prolonged air travel. Alveolar arterial oxygen gradient is normal. Or is he a 56-year-old woman undergoing chemotherapy for breast cancer, or a 62-year-old man who underwent hip replacement surgery 4 weeks previously. He says a 72-year-old man who had an acute MI 2 weeks ago. Okay, so we're looking for which of the following patients, in which of the following patients who present to the emergency with acute dyspnea would a positive D-dimer result prompt additional testing? Okay. So if you remember the modified Wells score, if you look at most of the scenario painted here, I think they would all be associated mostly with an elevation in D-dimer. For example, a woman who is 32 weeks pregnant. That's why we say D-dimer has it has a negative predictive value, but it also has its drawbacks because there are many causes of elevated D-dimer, like sepsis and myocardial infarction, like the patient he had, patient with cancer, like the woman in C, breast cancer, and those who have chest infections, pneumonia, and even post-op. So D-dimer can be elevated. So it has a negative predictive value because if it is negative, we can say that PE is unlikely. However, if by the time one calculates the score is, if you do a 2 predictive score, and then you have a score of 4 and above, you won't even need to do a D-dimer. You just go straight to your CTPA, even though now we're saying the high resolution CT is what is more used because it's non-invasive compared to the CTPA. So for all of these options here, the one that one will go ahead to do additional testing is option B, the 48-year-old man. Of course, he has no past medical history, but he presents with calf pain, which could mean he has a DVT. And then this is following a prolonged air travel. So even though the arterial oxygen gradient is normal, but because the D-dimer is positive, I think that kind of patient should have additional testing. Because if you look at the other options, a woman who is pregnant, 2nd week gestation or third trimester, 2nd trimester, D-dimer is usually elevated. In a patient, it to be high, to be positive. So in a patient undergoing chemotherapy already has a cancer, it will be elevated. It's expected to be post-op, it will be elevated following myocardial infarction. Okay, so but in this other patient that had a long history of long travel, has calf pain, then past medical history, he was fine actually. So that's the kind of patient, even though the saturation looks okay, it's a patient to look further, to go ahead to do further tests. Thank you. So I wouldn't know, is there any comment here or any addition? Okay, so if there's none, I'll move up to 150 now. 150 is about a 42-year-old woman presents to the emergency department with acute onset shortness of breath. She recently had a visit to her parents out of state, and she rode in a car for about 9 hours each way, so 18 hours. 2 days ago, she developed mid-calf pain and swelling, but she thought that this was not unusual after having been sitting with her legs dependent for the recent trip. On arrival to the emergency department, she is noted to be tachypneic. Her vital signs are blood pressure 98/60, heart rate is tachycardic 114 beats per minute, tachypneic respiratory rate 28. Her saturation was 92 in room air. and she weighed like 89 kg. The lungs were clear bilaterally. There is sorry, call came in. Sorry, call came in. So there's pain in the right calf with dorsiflexion of the foot, and the right leg is more swollen compared to the left. An arterial blood gas measurement shows pH of 7.54, callosis, PCO2 of 25, partial pressure of CO2, 25 millimeter mercury of oxygen, 68 millimeter mercury. Kidney and liver function are normal. So a helical CT scan confirms a pulmonary embolus. All of the following agents can be used alone in initial therapy in this patient, except, so they already confirmed the patient has PE. So we're looking for which of the anticoagulants you can use. Enoxaparin, 1 milligram per kg subcutaneously twice daily. Sure, we can use that. Fondaparinux, 7.5. Tinzaparin, I don't really know this, but I don't know that. But I know it's one of the parins. Unfractionated heparin, IV adjusted to maintain activated partial thromboplastin time 2 or 3 times the upper limit of normal. I think we can do that as well. Then the last option talks about warfarin, 7.5 milligram once daily to maintain INR at 2 to 3. So I think we have our answer here, which is warfarin. So we can't use warfarin alone as initial therapy when we're treating thromboembolic disease. And the reason is that one, warfarin has a slow onset of action. So it's a vitamin K dependent. So it has a slow onset of action. Usually, it is started with like we do in our practice, so quick lexine, and okay, so that even if ultimately the patient needs warfarin, you would have to start with something that acts faster before the onset of action for warfarin, which is usually delayed, can be up to 5 days. Then again, we know that warfarin has is initially prothrombotic by the time it started. So in this type of patient that has confirmed PE, warfarin will not be what we'll use alone for this patient. So the answer, the except there is will be E, using warfarin alone. Thank you. Please see there are comments or addition. Thank you.
Okay, so like was mentioned previously, this book is a bit old. I don't know what year. I was trying to check the first couple of pages, but I couldn't find it. So someone mentioned they had the 20th edition. I think it's Chief Sawa. If you could just help us drop it on the group so we could look at it. But why I'm mentioning this is we see in all of these options, the NOACs or DOACs are not mentioned. We know that they are now part of treatment for, they can be used for pulmonary embolism. Tinzaparin is a low molecular weight heparin, to be. But of course, the most commonly used enoxaparin, yes. So again, apart from the NOACs are not here, even though all of these other ones can be used. I think they mentioned in the diagnosis helical or spiral CT. I think now mainly the CT pulmonary angio makes it easier to actually see the vessels and the thrombus and where it is, as opposed to having to do invasive pulmonary angio or just the plain CT. Then okay, yeah. So, and I think we've already done previously like risk stratification for pulmonary embolism. So I think we may not need to bring it up here. All right, thank you. So I just wanted to mention the NOACs or DOACs.
Thank you very much. Maybe when we look at the 20th, maybe that would be but I think even if they don't, this option is to compare with this offering here.
Of course,
I agree that we should, if it's possible to look at it, maybe they might introduce some of the novel oral anticoagulants as part of the discussion. And then I think from the new guidelines, we can use them straight up, unlike previously.
There are some of them. I think there's one that might need to be overlapped now. I don't, but yeah, they mostly can be used just ab initio. Of course, depending on the risk. For somebody who would need like thrombolysis, but for just anticoagulation, they can.
Okay. Thank you very much. That's very helpful.
Okay. Thank you very much, Dr. Ituri, for going through that. We should be looking at the guideline of pulmonary embolism tomorrow. So I think it will also cover that. Dr. Ituri, I don't know. Let's go back to, would that be 81 to 90? If person to take it is around. If not, we just do my part. Okay, thank you very much. Dr. Olalekan, please, are you set to? Chief Olalekan, good evening, sir. Please, are you set to take it 1 to 90? Dr. Olalekan. Okay, so if it's not ready, maybe I should just take my, okay. But we can't hear you, sir. We need you to start now if you are ready. You're still muted, sir.
Okay, hello, please, can you hear me now?
We can overhear you with a lot of echoes.
Okay, sorry, I had to log off from the other device. I think the audio was a bit poor. I wasn't. Okay.
We can hear you. Thank you, sir.
So I'm taking, good evening, everyone. Sorry, I joined a bit late. I'm sorry. Okay, so I'm starting with question 81. Okay, so it goes towards, it said 63-year-old man presents with new onset exertional syncope and is found to have aortic stenosis. In counseling the patient, you tell him that your therapeutic recommendation is based on the observation that untreated patients with this presentation have a predictive average lifespan of A, 5 years, B, 4 years, C, 3 years, D, 2 years, then E, 1 year. Oh, thank you once again to the Dr. Itubi. I think he gave us an extensive overview of aortic valve disease, talking through aortic stenosis and aortic regurgitation. I think looking at the natural history of aortic stenosis, I think for those with congestive heart failure, I think they usually have, I think, about 1.5 to 2 years. I think those with angina, think about 2 to 3 years. And then syncope, I think about 3 to 5 years. I hope I didn't mix it up. So in the case of this patient that was actually having exertional syncope, the average lifespan is actually supposed to be 3 years. So the for question 81, the best of the answer to that is actually option C, which actually gives 3 years. So, but for dyspnea, it's actually 2 years. And then those with congestive heart failure, I think about 1.5 to 2 years. Okay, I don't know if there's any additional contribution to that.
Okay. Thank you very much. Let me just add to that. I have a code for that. ASD,
Okay.
angina, S syncope, D. So for angina, 2 years, syncope 3 years, and for dyspnea 5 years.
Okay.
Yeah,
Thank you, sir.
Thank you.
Okay, so I move to the next one. Okay.
Hello, sir. What was the answer to this number 81? Sorry.
Is C. That's the 3 years. 3 years.
Chief examiner, your network is poor, sir. If you can type in, sir.
Sorry, there's a meeting.
Hello? Should I move to the next one? Or
His network is poor. If you can type in, please move to the next one.
okay, thank you. So for question 82, Mr. Belliard is an 82-year-old man who you previously followed in clinic. He was last seen 3 years ago when he noted an occasional syncope. Subsequent work.
Hello, can you hear me now? Hello?
Okay, we can hear you now.
Okay, yeah, still on that 81.
Okay.
I think heart failure and all the symptoms of heart failure, shortness of breath, has to do with 1.5 to 2 years. Then syncope is 2 to 3 years or 3 years at most. Then angina is 3 to 5 years. That's the natural history.
Okay, sir. Noted, sir.
Okay. Thank you for the contribution, sir. Okay. Back to question 82. So Mr. Belliard is an 82-year-old man who you previously followed in a clinic. He was last seen 3 years ago when he noted occasional syncope. Subsequent workup revealed severe calcific aortic stenosis with an aortic valve area of 0.7 centimeter squared and mean gradient of 45 millimeter mercury. At that time, you recommended surgical aortic valve replacement. On the day of his operation, however, Mr. Belliard called to say he really didn't feel quite sick enough to undergo open heart surgery, and he will be back in touch when he was ready. He missed all subsequent follow-up appointments. Today, he presents to the emergency department after 7 weeks of lethargy and dyspnea. His blood pressure is 82/68 millimeter mercury. An heart rate is 110 beats per minute. He has an ECG showing sinus reading. His carotid impulse is weak and delayed, and extremities are cool to the touch. You again appreciate an S4 on auscultation and a grade 3 late peak systolic murmur. His renal and liver function are now impaired, and urine output is poor. The cardiothoracic surgeon on call defers emergent surgical valve replacement due to his acute renal and hepatic injury. Which of the following would be a reasonable therapeutic option to improve Mr. Belliard's short-term perfusion to permit aortic valve replacement? A, atorvastatin 80 milligram. B, digoxin 250 microgram IV once, and then 125 microgram oral daily thereafter. C, metoprolol 5 milligram intravenous serial dosing targeting a resting heart rate of 60 to 70 beats per minute. D, percutaneous aortic balloon valvuloplasty. E, phenylephrine, continuous IV infusion titrated to a mean arterial pressure of greater than 65. Okay, it's a very long read. So looking at the case scenario, we have a 82-year-old man who has been, who actually has severe aortic valve stenosis, calcific aortic stenosis, been scheduled for surgery, but lost to follow up. And the initial assessment showed an aortic valve area of 0.7 centimeters squared, and the mean gradient, which actually characterize there is actually a severe form of aortic stenosis. And it was lost to follow up for a few weeks. But by the time he's now presenting, he presented in worsening of his condition, now presenting with features of cardiogenic shock. Why? His blood pressure was 82/68 millimeter mercury. The systolic blood pressure is less than 90. Then he also had tachycardia, heart rate of 110. Although his ECG still showed that he has sinus reading, doesn't suggest any form of arrhythmia. He still has the weak pulse. And then now, because of the hypoperfusion, because of the poor systolic function and the cardiogenic shock, his renal function is now affected. Urine output is poor. He also has affectation of the liver because of reduced perfusion of the kidneys and the liver as well. So because of this of his worsening condition, the cardiogenic shock from the heart failure, the cardiothoracic surgeon actually defers emergency surgical valve replacement because of this multi-organ dysfunction that he already has. So what we expected to now, the question is now, what will be the next line of action, at least pending, to help actually to improve his both his renal and then hepatic function, pending when he will have aortic valve replacement. We're all aware that when a patient has aortic valve disease, surgical or intervention is still the best line of management. There's no amount of drug that, especially when it comes to aortic valve stenosis, there's no medication that actually helps to reduce mortality or help to improve outcome in them. So looking at option A, he said atorvastatin. Yes, atorvastatin may have been beneficial because looking at the pathophysiology of aortic valve stenosis because of the atherosclerosis may be beneficial, but in this case, it will not actually help to improve the blood pressure or reduce the tachycardia that the patient has. So it may not be of benefit in this stand. The next one is digoxin. Yes, digoxin would actually improve the cardiac contractility, but it could actually worsen it could actually worsen the aortic valve stenosis. And considering that the patient also has poor urinary output, that patient actually has something that looks like an acute kidney injury. And so digoxin is actually contraindicated. If you give digoxin, it actually increases the risk of toxicity in the patient. Now, the third option is that of metoprolol. Beta blocker would not also be of benefit in this patients. Fourthly, option D, percutaneous aortic balloon valvuloplasty would actually be of benefit, would actually be like a stopgap before, with that, the renal perfusion could actually improve, as well as the acute hepatic injury, which has also occurred as a complication in that patient. So this could actually serve as a stopgap before going ahead with the aortic valve replacement. Other option that could actually be used actually the mechanical circulatory support could actually be used. And then also intra-aortic balloon pump could actually also be of benefit in patients with severe aortic valve stenosis with worsening condition. Now, for the final option E, the phenylephrine continuous infusion, phenylephrine will not be of benefit in this patient because it's actually an alpha agonist, and it would actually help to increase the blood pressure, but because it's acting at the peripheral, causing peripheral vasoconstriction, it could actually worsen the resistance through which then actually worsening the left ventricular work against the resistance. So it's actually counterproductive in this case. So the reasonable thing to do or option to pick is actually that of option D, the percutaneous aortic balloon valvuloplasty. Thank you. I don't know if there's any further contribution or clarification. Thank you.
Okay, maybe let me just add that the patient has severe, aortic stenosis, and is already in some cardiogenic shock. You see the blood pressure in the response, in sympathetic response. The area is very, very small, 0.7, and the mean gradient 45. So if you are looking at option C, any use of any negative inotropic or chronotropic agents will not be helpful in this patient, because if we reduce either the heart rate, which will have impact on the cardiac output, that would further worsen, the other comorbidities the patient already has. So if we compromise the heart rates, or if we reduce the stroke volume, that would reduce the cardiac output. And already this patient has compromised renal function. So that will not be the best thing to do. Okay, so like you mentioned, the percutaneous aortic balloon valvuloplasty, that would be, at least in this option, that would be the most feasible thing to do. Okay, because it's just a bridge to definitive therapy, actually, and the patient should actually have a surgical valve replacement. So even though if you give the digoxin can, it's not likely going to do much in terms of increasing the stroke volume. And in the patient that already has poor renal or impaired renal function, that's not a good patient to use the digoxin for. Yeah. Thank you.
Okay. Thank you for the addition. Okay, any other contribution? Or do I move in the absence of none, then I proceed to the next one. Next question, question 83. Okay, so for question 83, it says an 85-year-old former lawyer presents with several months of accelerating dyspnea on exertion and lower extremity edema. On examination, you note a laterally displaced point of maximal impulse and an S4 gallop. She has a grade 3 systolic murmur at the base, radiating to the carotid arteries. A transthoracic echocardiogram reveals a left ventricular ejection fraction of 25% with global hypokinesis. The calculated aortic valve area is 0.8 centimeter squared, and mean gradient is 25 millimeter mercury. What is the next most reasonable step to determine whether this patient will benefit from aortic valve replacement? Okay, so option A, cardiac magnetic resonance imaging to evaluate ventricular scar and aortic valve morphology. B, cardiac positron emission tomography, that's PET, to determine ventricular viability. C, coronary angiography to evaluate for the presence of obstructive coronary disease. D, double timing stress echocardiography. E, right heart catheterization to document cardiac output and filling pressures. Okay, so looking at this case clinical scenario, a patient that actually has aortic stenosis, but now having features of heart failure, worsening exertional dyspnea with lower extremity edema. Then it has grade 3 systolic murmur. Then the transthoracic echocardiograph actually showed left ventricular ejection fraction is actually 25, has a reduced ejection fraction with global hypokinesis. Now, the aortic valve area is 0.8 centimeters squared. Then the mean gradient is actually 25. Because if you look at that, this is not actually a true, because if it's actually a true severe aortic stenosis, we expect the mean gradient, transvalvular aortic pressure gradient should be more than 40, if I'm right, yeah, 40. But in this case, it's likely probably maybe a pseudo aortic stenosis. So to know whether this is actually a true severe aortic stenosis or is pseudo aortic stenosis. So the best option to do is actually to do a dobutamine stress echocardiography. And that also helps to assess for the ventricular or cardiac viability. And what will definitely happen, the response that one should get is that for case of true severe aortic valve stenosis, you have the aortic valve area, which would actually get lesser than 1 centimeter squared with an increase in the pressure gradient. Whereas for pseudo, okay, thank you, Dr. Okay, so but for the pseudo severe aortic stenosis, what will happen is that the aortic valve area will increase to greater than 1 centimeter squared, while the pressure gradient still remains less than 40 millimeter mercury. Now, looking through the option, so the option D, dobutamine stress echocardiography, will be the most reasonable step to take in, differentiating between a pseudo-severe aortic stenosis and a true severe aortic stenosis. All those other options that were actually those other options that were actually given, option A, the cardiac MRI, will also give information about the ventricular cardiac viability in this patient. I think the description of those findings actually shows a low gradients, a low pressure gradient, which is actually 25, a low flow, actually a low flow, low gradient, which is actually an indication to, one of the indications to actually do a dobutamine stress echocardiography. Thank you. I don't know if there's any other contribution or addition to this. Okay, I think probably, okay, maybe I should just read out what we have here. Okay, we have some posts on the chat. So a low flow, low gradient aortic stenosis with reduced ejection fraction. That is the mean gradient less than 40 millimeter mercury. Valve area, which is less than or equal to 1 centimeter squared. Then the left ventricular ejection fraction less than 50. Then I think the stroke volume index, if I'm right, then less than or equal to 35 mils per meter squared body surface area. So those are the characteristics of a low flow, low gradient aortic stenosis with reduced ejection fraction. So a low dose dobutamine stress echocardiography is recommended to distinguish between a true severe and a pseudo-severe aortic stenosis. So when there's an increase in the valve area to greater than 1.0 centimeters squared with increased flow, and then that identify patients with no flow or contractor reserve. Okay, thank you. I don't know if there's any other addition or contribution. Do I move to the next question?
Please move on, sir. Thank you.
Okay, thank you. So question 84. Okay, it says which of the following parameters is typically reduced in chronic severe aortic regurgitation? Okay, A, diastolic blood pressure. B, left ventricular afterload. C, left ventricular diameter. D, left ventricular preload. Then E, total left ventricular stroke volume. Okay, looking at this, patient actually has a severe aortic regurgitation. Now, looking at those options that we have, a diastolic blood pressure in chronic severe aortic regurgitation is actually reduced. For the left ventricular afterload is actually usually elevated. Then the preload also elevated. Then the left ventricular diameter too is also increased. Then the total left ventricular stroke volume is actually increased. I don't know if I can actually get it help as to why the diastolic blood pressure is actually reduced. Thank you. Maybe. Please, can you hear me?
Yes, we heard you.
Okay, please, I don't know if someone can actually help with that. It's actually the diastolic blood pressure that is actually reduced.
Hello?
Hello, okay, hello, okay. Dr. Conte, thank you.
Yeah. So the diastolic pressure is expected to reduce in chronic aortic regurgitation because what maintains diastolic pressure is a competent aortic valve and the recoil of the aorta during diastole. So that is what maintains diastolic pressure. So if you have chronic severe aortic regurgitation, among those parameters listed, the diastolic blood pressure is the one that is seriously reduced. And that reduced diastolic blood pressure, one of the important consequences of that is the reduced coronary perfusion. That is why people with severe aortic regurgitation can actually have angina symptoms when they exert themselves because the low diastolic blood pressure compromises, coronary perfusion, and they can present with angina as symptom. Thank you.
Thank you. Okay, any other addition? Okay. So in the absence of none, I'll move to the next question. Okay, that's why. Okay, that's the wide. Okay, pulse pressure. Okay, thank you. Okay. Okay, I think this is also part of the several signs that we have in a patient with aortic regurgitation. Okay, the wide pulse pressure. Okay, thank you.
Another elementary way to look at it is the curve is actually measuring the flow force of the blood, measured from the arm. And during systole, the heart is pumping and the heart is pushing that blood. Then during normal diastole, that force has been withdrawn. So you're able to get a slight reduction because the systolic force is no more there. But with regurgitation, there is further reduction because of that regurgitation. There is further reduction of that blood flow force that you are supposed to get during diastole. So that's another way to look at it.
Okay, thank you so much. Thank you so much, sir. Okay, so move to question 85. Okay, please, can you help me scroll up a bit? Just move it up a bit. Okay, so it says you are caring. Okay, thank you so much. Okay, so you are caring for a new admission to the cardiac intensive care unit, a 21-year-old woman with connective tissue disease. She presented with acute shortness of breath and a chest x-ray showing diffuse pulmonary edema. Physical examination revealed a soft, short, early diastolic murmur at the right upper sternal border. And an emergent echocardiography showed severe aortic regurgitation with an avulsed right coronary corpse. CT chest images showed no aortic dissection. On arrival to the coronary care unit, she's intubated and sedated. Blood pressure is 110/50 millimeter mercury, and heart rate is 115 beats per minute. Our urine output is poor, and extremities are cool. The cardiothoracic surgical team is tied up in a heart transplant and won't be able to take this patient for at least 4 more hours. What intervention is most likely to help maintain our end organ perfusion until surgical intervention? What intervention is most likely to help maintain our end organ perfusion until surgical intervention? A, Esmolol continuous IV infusion titrated to a heart rate of 60 to 70 beats per minute. B, intra-aortic balloon pump. C, IV nitroprusside. D, IV norepinephrine. E, IV vasopressin. Okay, so here we have a case of a patient, 21-year-old woman, connective tissue disease, has severe aortic regurgitation, then has features of heart failure, diffuse pulmonary edema, then tachycardia, then also in shock with a diastolic pressure of less than 60 with a wide pulse pressure, and then urine output is actually poor. So pending when the definitive intervention, which is the surgical intervention, will be done, what will help to maintain the organ perfusion pending that. Okay, so we have option A, said Esmolol. Okay, that's a beta blocker. And giving a beta blocker here would actually be counterproductive because lowering the heart rates could actually I think will not be of benefit because the heart rate actually helps to maintain the cardiac contractility. Okay, that's my view. Then number 2 is B is the intra-aortic balloon pump. Considering that there is an avulsed right coronary corpse, I don't think that will actually be of benefit there because considering that the avulsed right coronary corpse would have probably been what led to the severe aortic regurgitation in the first place. C, IV nitroprusside. Okay, I think IV nitroprusside could actually be of benefit, said to actually reduce systemic vascular resistance and then also reduce the driving pressure for the regurgitation. So a careful administration of the nitroprusside could actually help to stabilize the organ perfusion pending when the aortic valve, the surgical intervention will actually be done. Okay, for the vasopressin, I don't think that will actually be of any my answer that I'll pick there is actually the option C, the IV nitroprusside. I would like to entertain any contribution at this moment. Thank you. Is there any contribution?
Yeah, nothing is in the chat box.
Okay, there's okay. I think there's question and a comment. Okay, Dr. Rukaya says, okay, is she really in shock? Okay, given we've just seen that low diastolic pressure may be reducing. Okay, I think probably what she had probably is maybe heart failure, considering the diffuse pulmonary edema that she has. That's actually my thoughts. Or I would still like to entertain any other contribution to that. Yes, I think the blood pressure that we have, 60, the pulse pressure of 60 is actually wide. That could be because of the low diastolic pressure rather. But looking at the shortness of breath, she's actually showing a diffuse pulmonary edema. I think probably she's an heart failure, probably not necessarily but considering that she has extremities are cold, then the urine output is also poor. I don't know. That's actually, I don't know if there's any other contribution to this.
Yes, I thank you so much, Dr. Laliho. In my
Okay.
opinion, the main problem here is this patient has acute pulmonary edema. From the acute, he said it's an avulsion of the what's it called? Of the aortic, yes,
Right coronary cusp.
yes, of the corpse. It's just an avulsion, one avulsion there. And if we tend to look at all the options here, really, in the setting of an acute pulmonary edema, you will not use a beta blocker. And it's not even, there's no dissection here. There's no BP. We are not trying to calm pulse. We are not trying to count. So Esmolol, beta blocker is a no-no here. If you look at option B, triaortic balloon pump is contraindicated in aortic valvular disease. We don't even use it because it will worsen the patient's problem. Then if you now look at these vasopressin and norepinephrine, what are they going to do? The main problem we have here is not that the heart is not pumping. The main issue here is the backflow that has resulted into acute pulmonary edema. So what are the other medications that we can use in acute pulmonary edema aside furosemide or loop diuretics, as the case may be? We need nitrites, we need nitroprusside. All these ones will help in the preload. So that's why option C will be the best option for me here, because the main issue is not really pump failure. The main issue is the backflow, which is the preload, and the acute pulmonary edema. Thank you.
Okay, thank you.
Then additionally to, thank you, Dr. Rimoladi. Additionally, if you look at those other agents, use of vasopressin and norepinephrine, those ones will cause some vascular resistance, right? So they'll increase vascular resistance. And we know mostly aortic regurgitation occurs in diastole, right? So if they would worsen the vascular resistance, the pressure to overcome that will be much more, right, for the flow to occur. So you will have the regurg even worsening. And that is why likewise you can use beta blockers in this type of patient, because the use of beta blocker will further, like increase the diastolic time. And once you increase the diastolic time, what you're doing again is you are worsening the regurgitation. So what looks most likely, like Dr. Rumoladi said, is the use of nitroprusside, because that will cause some relaxation or dilatation of the vessels. And that will reduce the effective pressure that is needed for the pumping. So it looks more tenable. And then we remember that coronary filling occurs mostly in diastole. So if you are using the intra-aortic balloon pump, okay, that you remember that it actually inflates in diastole too as well. So it looks more likely that for this patient, the use of nitroprusside is what would work better. Thank you.
Thank you.
Thank you very much, Dr. Olalekan. Please, let's continue. We have a long way to go.
Okay, so question. Okay, so please question 86. Thank you. Okay, I think you've moved faster than. Okay. Thank you. Yeah. Okay, so question 86. I think this appears to be a straightforward one. So, what's the most common cause of obstruction to left ventricular inflow? So, what's responding for the ventricular inflow is actually the mitral valve, so which allows blood to flow from the left atrium to the left ventricle. So, the most common cause is still rheumatic fever, rheumatic heart disease. So we have option A, congenital mitral valve disease, B, triatum, C, infective endocarditis with large mitral valve vegetations, D, mitral annular calcification, E, rheumatic mitral disease. So the most common cause is actually the option E, rheumatic mitral disease. All those other ones could actually be a cause of mitral valve disease. Then for the mitral annular calcification, it's actually commoner in the elderly. Common in the elderly. Okay, I don't know if there's any other contribution, or do I just move to question 87?
Sorry, what's the answer?
So it's option E, rheumatic mitral disease. Okay, but I said that mitral annular calcification is also seen more in the elderly. Thank you. Okay, so I move to question 87. Okay, so in cases of severe mitral stenosis, which of the following parameters is typically increased? I think this is also a straightforward, is actually the left atrial pressure, because when there is stenosis of the mitral valve, so the flow from the left atrium to the left ventricle is actually impeded. So in which case the pressure within the left atrium will actually build up, so would actually increase. So I think that's also probably a straightforward answer. So it's left atrial pressure. So, but for the cardiac output, we actually reduced because what will account for the systolic would actually be the since there is reduction of the flow from the left atrium to the left ventricle, the cardiac output will actually be reduced because of the reduced the volume would actually be reduced. Then the left ventricular diameter will not increase. Then also the pulmonary vascular compliance also will not increase at all. Okay. So I move to question 88. So for question 88, it said you are caring for a 42-year-old woman with a prior history of rheumatic fever and resultant mitral stenosis. Her valvular disease is currently moderate. You know that mitral stenosis causes an elevation in the left atrial pressure, which over time can cause cardiogenic pulmonary edema and pulmonary hypertension. All of the following will result in an elevation of left atrial pressure and potential worsening of the lung function, except, okay? So looking at those options, we have option A, anemia, B, isoproterenol, C, metoprolol, D, pregnancy, E, running on a treadmill. Okay, so if you look at these, patient actually has mitral valve stenosis. So if you look at tachycardia actually helps to prolong the diastolic timing. So whereas tachycardia actually shortens the diastole. whereas the bradycardia actually prolongs the diastolic timing. So things that would actually help to increase said all of the following will result in an elevation of left atrial pressure. So things that will help to increase the left atrial pressure, said except, I hope I'm not mixing this thing up. This is anemia. Okay, now, so if you look at it, anemia will cause tachycardia. Pregnancy can be associated with tachycardia. Then running on a treadmill exercise will lead to tachycardia. Then I think I saw proterenol would actually lead to tachycardia. So all this would actually increase the left atrial pressure, whereas metoprolol, which is a beta antagonist, would actually lower the left atrial pressure. So is the only one that will not worsen it. And because like I said earlier, the tachycardia actually helps to shorten the time the diastolic timing, whereas bradycardia actually prolongs the diastolic timing. So I think the option is that I picked is option C. That's the except. I don't know if there's any other addition. Thank you. Okay, in the absence of no comment or question, and I move to question 89. Okay, so for question 89. Okay, thank you. So, okay, beta agonists are detrimental in mitral stenosis. Thank you. Okay, so for question 89, Mrs. Brin presents to the emergency department with acute worsening of shortness of breath. She's an 84-year-old woman with severe mitral stenosis who is scheduled for percutaneous mitral balloon valvotomy in 3 days. However, today while cooking chicken salad, she noted the onset of overwhelming weakness and dyspnea. On evaluation, she appears dyspneic and in mild distress. Oxygen saturation on the room here is 91%. Heart rate is 55 beats per minute, and the blood pressure is 110/80 millimeter mercury. She has rails to the mid-lung fields bilaterally. You note that her reading is irregularly irregular, and ECG confirms the new onset of atrial fibrillation. You suspect that she has a very high left atrial pressure, causing pulmonary edema. All of the following therapeutic interventions will help to lower her left atrial pressure, except. Okay, so looking at the options, we have option A, IV furosemide. Actually, furosemide will actually help to lower the left atrial pressure, help to reduce the preload, actually helps in really beneficial because of the heart failure that the patient actually has, the cardiogenic pulmonary edema. So B, percutaneous balloon mitral valvulotomy would also help to reduce the left atrial pressure in these patients. Then synchronized DC cardioversion, yet considering that this patient actually has a new onset atrial fibrillation. So when patient has a DC cardioversion, that will actually help to revert the patient to sinus rhythm, and this will also help to lower the left atrial pressure. Now, option D says transvenous pacemaker placement and pacing at a rate of 90 beats per minute. This will not be beneficial in this patient. Number one is that the patient doesn't have either a block, either a complete heart block, or is type a second degree type 2 AV block, or any other compelling indication to actually give a pacemaker. And so these could actually be detrimental in this patient. So option E, it says all of the above will help to lower the left atrial pressure. Yes, the IV furosemide will do that. The percutaneous balloon mitral valvulotomy, the synchronized DC conversion would actually help to that. So the one that is accepted is actually the option D, the pacemaker placement, pacing at the rate of 90 beats per minute. I don't know if there's any contribution or addition to that. Thank you.
Sorry, Olaleko, not to question your choice of
Okay.
the but do we really do a DC conversion for AF? Just asking.
Okay, looking at it, well, I think probably maybe
I don't know is equally an answer. We'll move on and go to the next one. All of us will go and research. That was just my concern when I was looking at
Chief, I think we do.
Cardioversion can be
Cardioversion,
done
no.
for
We do it, no.
almost any arrhythmia.
We do it for
So we
everything,
can.
no.
If they are
Yeah,
not stable, you cardiovert.
okay, for hemodynamically unstable patients.
Yes.
Unstable ones, you cardiovert straight up.
You cardiovert
can
straight
even
up.
do
They are not
cardioversion. There's no, if a patient is stable and has AFib, you can do it electively if you want.
Okay,
That's what I feel. Electively if you want, but of course you have to anticoagulate over a given period of time. But if your patient has AFib and is hypotensive, the BP is down, you just go ahead and cardiovert as you're meeting the patient. You don't need to check if you don't need to check the left atrial appendage or anything. Just this cardioversion straight up and then follow up. I think that's what is in the guideline.
In the
In fact,
index,
the guideline says if you're able to time the AF to less than 48 hours, and then the patient is in hemodynamic compromise, you go ahead and do cardioversion. Cardioversion is a treatment for AF. In fact, when you're looking at rhythm, it's part of the rhythm control. Rhythm control, you can do pharmacologic control, and then you can do electrical cardioversion. And of course, some people, even when they are stable and then when they are not in hemodynamic, they can opt to go for cardioversion as a treatment. In that case, it is elective. But if the AF cannot be timed to less than 48 hours, then you do anticoagulation with rate control for 3 weeks, and then if you're using warfarin, you do your INR. If you're using unfractionated help, of course that wouldn't be. If you're using once after 3 weeks, you can now cardiovert.
okay, with the mentioning of guidelines, it means there wouldn't be further questions. Thank you.
Okay, thank you for the contribution. Okay, I think I would just like to read some of the things on the chat. Okay, it says beta agonists are detrimental in mitral stenosis. Then sinus bradycardia is also helpful in mitral stenosis. Thank you. So I'll go to the last question that I have, question 90. Please, can you kindly help me scroll up a bit? Thank you. Okay, thank you. I'm grateful. So question 90 said, 34-year-old man with rheumatic mitral stenosis is referred to you for evaluation. He enjoys playing recreational soccer and has no limitation or symptoms. His heart rate is 65 beats per minute at rest. A transthoracic echocardiogram reveals a normal left ventricular size and function, a moderately dilated left atrium, and a mitral valve area of 1.7 centimeters squared, and relatively thin non-calcified leaflets. ECG shows a left atrial enlargement and sinus reading. On exercise stress testing, is calculated pulmonary artery systolic pressure at peak exercise is 40 millimeter mercury. Which of the following treatment plans do you recommend? A, metoprolol, 25 milligram oral twice daily. B, percutaneous mitral balloon valvotomy. C, periodic cardiology assessment and echocardiographic monitoring. D, sildenafil 20 milligram twice daily. E, surgical mitral valve replacement. Okay, so looking at the clinical scenario that we have, a 34-year-old man diagnosed of rheumatic mitral stenosis. Number one is that he has no symptoms. By the information that we've gotten, that he enjoys playing recreational soccer, so he doesn't have any symptoms. He has no limitation, no breathlessness, no chest pain, nothing. His heart rate as well as 65 beats per minute. Then looking at the echocardiography, it has a good left ventricular function. There's then also the normal size left ventricle. Although it has a dilated left atrium, which may be expected because of the mitral stenosis. The mitral valve area is 1.7 centimeters squared with a thin non-calcified leaflet. ECG just showed left atrial enlargement. It is in sinus reading. Doesn't have arrhythmia or any form of supraventricular arrhythmias. Okay, so on exercise stress testing is a peak artery systolic pressure at peak exercise is 40 millimeter mercury. So A, it says a metoprolol. Since the patient wasn't symptomatic, giving metoprolol is not of any benefit. So option A is false. So percutaneous mitral balloon valvotomy, patient is not symptomatic. Aside that, it has a normal left ventricular size and function. I think the valve area is 1.7. I think it's probably moderate. I think it has a moderate, asymptomatic moderate mitral stenosis. So that will not be beneficial. C, it says periodic cardiology assessment and echocardiography monitoring. I think that is what will be more beneficial in that patient. Monitoring the mitral valve area, then monitor the left ventricular size and function, and then assessing the patient for any symptoms or whatsoever. So I think the option is option C. But let's go to looking at option D. Sildenafil 20 milligram twice daily. The patient doesn't have any symptoms. Then also the pulmonary artery systolic pressure at peak is said to be 40. So at the point whereby one may probably want to reduce the pressure is when the pressure is as high as 60 millimeter mercury with exercise, and then at rest, I think about greater than 50 millimeter mercury in the patient. Then lastly, surgical mitral valve replacement. Considering that this patient is asymptomatic, replacing the valve is not of any benefit. Rather, periodic assessment and then monitoring with transthoracic echocardiography monitoring will be of great benefits in this patient. At this point, I would like to entertain any contribution or further question. Thank you so much.
Okay, thank you very
Please,
much,
am I?
Dr.
Okay. Oh, thank you.
Olalekon. Just to thank you for
thank
the
you.
session. It was really very helpful. Thank you for taking your session. We still have a long way to go. Are there more comments, if any? If there's none, so that
Maybe a comment on this
okay,
question.
great.
Yes. Thank you, Dr. Laleko. I don't know. Just like we've been saying, there's an edition that is higher than this. The new guideline now for these mitral valve replacements, well, is that surgical mitral valve replacement in this category of patients is a class 2 indication. And these patients in this class at this age, with no comorbidity, young, and they like to them rather benefit from surgical mitral valve replacements as a class 2 indication, weighing the risk of surgery, which has been reduced to very less than minimum with advanced um, and increased um, um, surgical exposures from the surgeons. So if these surgeries to be done in where we have people that do a lot of surgeries in a year, you understand? So we don't have to wait and monitor again, really. This is a class 2 indication according to the new guidelines. So I don't know. So in case we see it in exam, if it's framed in another way, it's actually a class 2 indication because the longer we wait, the poorer the prognosis for those people. So that's just my addition. Thank you.
2A or 2B?
Sir?
2A or 2B?
2B. 2B.
Thank you.
Thank you. Thank you for that very helpful addition. I think we should look up the guidelines too. That would be very helpful.
I think Dr. Ruki took us.
Okay, yes, she did. But it's good to
Yeah.
look at those things again,
Okay.
Refresher.
She took us, if we remember, we should always remember this staging. It will really help. This stage A, stage B, C, D.
C, D.
Yes, so we should know D is valve replacement, either surgical or trans catheters, the case may be. Then stage C now, we have the symptomatic, asymptomatic. However,
Yes.
unlike what we have in aortic regurgitation for mitral or aortic stenosis, rather, for mitral stenosis is quite different somehow. And even mitral regurgitation is quite different. So maybe that's just
Okay.
a little that since surgeries are being done and the risk of surgery goes lower and lower. So a young child, you know that even if you wait, you still end up doing this surgery eventually. So why not just do it when the patient is okay?
Okay, please, can I read something? I think I saw something just, okay, I think from the slides that Dr. Rukaya gave to us, follow-up for asymptomatic mitral stenosis, ESC 2021. It says serial testing of asymptomatic patients with clinically significant mitral stenosis should be followed up yearly by clinical and echocardiographic examinations and at longer intervals, 2 to 3 years, in case of moderate stenosis. That's ESC 2021.
What class?
Okay. Okay. Well, I just copied that. I didn't look at it. It was just
Maybe we'll just check it.
okay.
Thank you very much. I think Dr. Rimolade, was that the guideline you were referring to? This same one he read from? Or is there another one?
There's a newer American. We have BSc American. Okay,
Yes,
so that was yes, that one is 2022. Thank you.
Hey, all these things. Thank you very much.
Please help us send it. Please, if you have the 2022, please help us send it to the group. Thank you.
Sorry, Dr.
So can I just ask which one are we likely to lean on or lean towards? Okay, sorry, Ruki, go on.
No, I'm trying to open the document. My device is being slow. Is that for asymptomatic severe or asymptomatic moderate? because the valve area matters. This particular patient has 1.7, so he's not yet severe, but I mean, I was just trying to open the guideline, Dr. Malade, if you could clarify. Is it for asymptomatic severe or asymptomatic moderate that we should consider doing surgical replacement? I know for the moderate, they needed to have like additional parameters, either on echo or something to qualify.
This one is not even, it's not about symptoms or no symptoms. Maybe I will just check it and send it. What I read, so even a video I listened to, where, you know, when they do guidelines, they now do this video summary of the new things that have changed from the previous guidelines. So that was what I checked up, which says both for mitral regurgitation, mitral stenosis, since the surgeons, they are getting more and more at skilled, and the risk of surgery is now so less. So for patients, the class 2B, that's what I'm saying, still 2B. If patient wants to have surgery, they can go ahead and have it as a class 2B indication. Since even if you are following, you will follow up and you will still have the surgery anyway. The treatment of choice for stenosis, drugs will not really retard the progression, as the case may be. So we do surgery as soon as you can for this patient. That's just what we said. So it's not really if it's severe, asymptomatic, or it's not class, I'm not even talking of class C now. I'm even talking of B. Hello, Dr. Ricky.
Yeah, thank you.
All right, thank you.
Okay, I think I'm done with my sessions. Thank you so much.
Was so grateful. Thank you. It was a very helpful session. And I don't know if Dr. Philomena is on the call. She'll be taken from 91 through to 100. Yes, she's here. Please, can you hear me? Or can you hear us, Dr. Philomena? Dr. Philomena, can you hear us? Okay, can we move to maybe when she's able to speak, we'll take her. Adeyan is not yet stable. Dr. Ayodeji, are you able to take your session now? Please, any feedback? Let me be sure.
Yes, we can hear you.
Yeah.
Okay, Tubi, we can hear you.
Thank you. Take care later. Please, Dr. Ayodeji, are you able to take your session now?
Yes.
Thank you, sir. That will be 111 to 120, right? So when you're ready, sir, you can go.
Okay. On 11. Okay. You're attending your 12-year-old son Little League baseball game. The score is 2 to 2 in the night. In the night ironing, and your son's team is up to bat. On the first pitch of ironing, I think the batter fouls the ball directly back to the catcher's chest. The catcher immediately loses consciousness and collapses. Is pulseless with agonal respiration. A physician know that his survival depends most on which of the following. A emergent transfer to a cardiac catheterization lab for percutaneous intervention. That's false. The most likely thing here is patient had most likely commotise cordis, which is due to its non-blunt trauma, non-penetrating injury to the anterior chest. So if it coincides with the period of ventricular repolarization, so B, immediate transfer to a trauma center for repair of acute. This is unlikely. That's for. No intervention can impart. That's for. Prompt cardiac surgery to repair is unlikely. To prompt defibrillation, I think E is the correct answer. Hello?
I can hear you, sir.
Hello? So I said E is the answer here.
And then the commercial cordis what?
Yes. Non-penetrating injury to the anterior chest wall, and then if it occurs at the time of that ventricular repolarization, where you have that the ROT phenomenon. I think D is the, what's it called? E is the correct answer here. Any addition? Hello?
Yeah, we can hear you.
Okay. Any further control? I should go on.
I think you should move on. If there's any addition, they will call you. They'll call back to that point. Thank you.
Okay. A 47-year-old woman with a body mass index of 37 was recently diagnosed with type 2 DM. As part of our patient's education, you inform her that which of the following is the most common cause of death in adults with type 2 DM. A, coronary artery disease. B, infection. C, neuropathy. D, renal failure. E, stroke. I think it's A, because of risks of atherosclerosis, then coronary artery disease. And over time, they are prone to having the silent MI. From autonomic, cardiac autonomic neuropathy, which they can have too. So I think A is the correct answer here. Hello?
We can hear you. Please move on.
Just go on, sir. Just
Please
move on. If
call you
there's
back.
any reason to call you back or to add.
Okay. Mr. Daniels is a 49-year-old known well to your emergency department. Okay, thank you. Know what to your emergency department for frequent visits for alcohol intoxication. As for the on-call internal medicine officer, you are called to evaluate him for admission tonight. On arrival, he is only mildly intoxicated and able to provide a passable history. He claims that for the past 3 months, he has been increasingly short of breath with even minimal exertion and is experiencing overwhelming fatigue. He has also been awakening at night with extreme shortness of breath, only alleviated by sitting on the edge of his bed. So he has PND. His ankle have been swollen. On examination, his blood pressure is 140/45, has a white pulse pressure. Heart rate is 122. He has a bounding carotid pulse pressure and elevated jugular venous pressure. His PMI is laterally displaced. You clearly hear a low pitch headache sound directly following the S2 as unnecessary likely. You note glossitis and find that he lacks sensation to light touch below the mid-chin bilaterally. Basic lab studies are noted for an albumin of 3.2 gram per DL, creatinine of 1.4, sodium 134. Transthoracic echo reveals left ventricular dimension of 6.8 cm with ejection fraction of 70. That's an high output. You adroitly make the diagnosis and administer a substance to treat the underlying cause of Mr. Daniel's condition. Reassessment in 24 hours find him symptomatically improved with a blood pressure of 142/76 and a heart rate of 85. Repeat echo now is heavy size to be 6.2 cm in end. So which of the following most likely cause Mr. Daniel's condition to improve so rapidly? Folate, that's not likely. Penicillamine, the antidote for copper in Wilson's, that's not likely. Thiamine, yes. Well, I have put heart failure, wet beriberi. If you look at the scenario soon, you have the bounding pulse. Thyroxine is unlikely because doesn't have hypothyroidism here. So, but I think thiamine or wet beriberi, they have a bounding pulse, and the fact that following the administration of spontaneous improvements and the FVDD, of course, improved. In addition to presentation of glossitis too. So I think the answer is here is C. Alcohol intoxication, which will lead to thiamine deficiency and other chronic alcoholism. Thank you. The next is 114.
Okay, so I'm getting there. We have to be a bit faster
Okay.
because we still have time. We want to round up tonight. So
Okay. A
if you don't hear
65-year-old.
anything, just move on. If somebody
Okay.
has something, they'll call you back. Thank you, sir.
Okay. This 5-year-old former factory worker with a past medical history of rheumatoid arthritis presents to your primary care clinic complaining of fatigue. She also stated that she has been following. She also stated that she has the following symptoms: constipation, constantly feeling cold, even when the thermostat is set at 80 degrees Fahrenheit, brittle hair, and some lower extremities swelling. You expeditiously measure a thyroid stimulating hormone, which is greatly elevated. In regard to the present condition of our cardiovascular system, you expect a decrease in all of the following except. So this is a scenario of hypothyroidism because with the secondary increase in the TSH. So in hypothyroidism, there will be a decrease in the cardiac output, the heart rate too, they have bradycardia, they could have a low pulse pressure too, systolic blood pressure too can also be low. However, they have a prolongation in QT interval. Have pericardial effusion. So I think D is the correct answer here. So 115. In the current model describing the steps of atherosclerosis, initiation and evolution, which of the following constitute the first step? That is atherosclerosis. Arterial endothelial cell express adhesion receptors for leukocytes. That's not the first. Lipoprotein particles undergoes oxidative modifications. And then C, low density lipoproteins accumulate within the arterial intima. Yeah, that's the first. That's true. And that's likely to be followed by B, which is the lipoprotein particles undergo oxidative modifications, and after which the arterial endothelial cells, you have this overexpression of adhesion receptor for leukocytes, and then following which the macrophages and other leukocytes, they are recruited to the anterior intima, and lastly, of course, the macrophages become the lipid-laden foam cells. So I think C is the correct answer here.
Please, can you take the steps in order again? Sorry, thank you.
Okay, the first step is the low density lipoproteins that accumulate within when you have hyperlipidemia for risks of atherosclerosis. The low lenses that accumulate within the arterial intima, that's one. And then B, the lipoprotein particles, they undergo oxidative modification where you have production of super hydroxyperoxide, and then following which you have the arterial endothelial cells overexpress adhesion receptors for leukocytes. And then the macrophages, and that's the third one. Then number 4, the macrophages and other leukocytes, they are recruited to the arteria intima. And then lastly, macrophages become the lipid-laden foam cells. They are the endocytosis of lipoprotein particles.
Thank you, sir.
Okay, you're welcome. So 116. Which of the following statements regarding the pathophysiological consequence of an atheroma is true? An atheroma resulting in total vascular occlusion invariably causes infarction. That's not true. It may, but not all the time. An enlarging atheroma does not generally encroach on the arterial lumen until the plaque exceeds 40% of the internal elastic lamina. Okay, I'll come back to this. Most atheroma will eventually produce symptoms in patients. That's false. May not most. Upon initial formation, the atheroma plaque usually grows inward towards the vessel lumen. It grows outward, not the inward. Vessels affected by atherogenesis tend to contract and get smaller in diameter. It contracts but increase due to compensatory enlargement. Is an increase contract but gets larger in diameter. So the correct answer is B. 116. 117. 117. Based on the 2013 cholesterol guidelines for ACC and AHA, all of the following groups are definite statin benefit group. All individuals who have, except who have clinical atherosclerotic cardiovascular disease, that's true is one of them, so it will be false. Individual with an elevated high sensitivity reactive regardless of low density lipoprotein cholesterol level or ASCVD rates. That's not part of there are 4 of them. Individual with LDL greater than 190 milligram per DL without a secondary cause, such as high intake of saturated or trans fats or various drugs. That's true, so it will be false. Individual without established ASCVD or diabetes who are 40 to 70 years old and who have LDL cholesterol of 70 to 189 milligram per DL and a calculated ASCVD rate greater than or equal to 7.5. That's true, so it's false. The patient with DM without established cardiovascular disease who are 40 to 75 years old and have LDL of 70 to 1. So the only one that's out of date is the second one. The other ones, they are all based on that 2013 ACC. So B is the other one here. 118. A 50-year-old man presents to your clinic to your clinic for his yearly checkup. Today is quite concerned about his future risks for heart attack and stroke after having read some concerning news articles in print and online. He has a history of vascular disease. He has gained some weight over the last decade, and his BMI today is 34 kg as an obese. And the lipid panel has shown so there is hypercholesterolemia, high TG, low HDL. So you calculate the hello? Can you move? Thank you. You calculate his ASCVD risk as 6% with the risk calculator provided by the ACCHA. The patient has read that his low HDL cholesterol has been identified as correlated with his risk of future cardiovascular disease. He wants to know what you can prescribe in regard to his HDL that would definitely lower his cardiovascular risk to the largest degree. What is the correct answer? An agonist of peroxisome proliferator activator receptor A. Well, from the literature, they will increase, but it will not provide any cardiovascular risk benefits. An inhibitor of cholesterol ester transfer protein will also do the same thing, but no cardiovascular benefits. Fenofibrates, the same thing. And nicotinic acid. Weight loss and physical activity, I think is the correct answer here. Thank you. All of the following are major determinants of myocardial oxygen demand, except, yes, the heart rate. That's true, so it will be false. Heart rhythm, with heart rate, there will be increase in the tachycardia, there will be increase in the work of the heart, increase the oxygen demand, and myocardial contractility. That's true, it will be false. Ventricular wall stress, yes, that's true, it will be false. It's the heart rhythm, has nothing to do with the heart rhythm. So B is the answer here for 119. $120. I think it was answered yesterday, but I can still go over it. Hello?
Yeah, please just go over it as
Okay.
last. Thank you.
Mr. Jackson is undergoing an exercise stress test. You know that as he progresses through his stress test, his myocardium will require more oxygen. How does the normal non-disease heart respond to meet it? Higher oxygen demand. Increase myocardial oxygen extraction during near constant coronary blood flow. That's unlikely. Increase oxygen extraction from the ventricular chambers. likely. Relative expansion of diastolic time period. Allowing increased coronary flow. Vasodilation of epicardial coronary arteries leading to a decreased resistance and increased coronary flow. Vasodilation of intramyocardial coronary vessel leading to increased coronary blood flow. Well, I think from it was E that we chose yesterday.
Yes, that was the answer we chose yesterday.
I think that concludes my part. So.
Thank you very much, Dr. Adeji. Thank you so much for doing your part. Thank you.
Thank you.
So, Andrew, can I hand over to you now? Are you able to do this? Okay.
Yes. Okay, somebody wants to say something. Thank you very much, Dr. Itube. Can I go to my part, please? That's one.
Yes, 101.
Yes.
Okay.
Thank you. Okay. Thank you very much, everyone. We still have a lot to cover, so I will try fast. Essence of the discussion, but you can always call me or prompt me back. So, question 101. A 22-year-old college student with no past medical history was seen in the urgent care clinic 3 days ago for coryza, myalgia, cough, and fever, which was typical of the viral upper respiratory illness making its way through the campus. He was given a cough suppressant and antipyretics and advised to remain hydrated. So he presented to the emergency department with lethargy and fatigue. He is obtunded with a heart rate of 120 beats per minute and blood pressure of 62 millimeters of mercury. His extremities are cool and JVP is elevated nearly to the mandible. Precordial auscultation reveals very quiet heart sound, an S3 gallop, and a soft murmur of MR. Emergent TTE shows no pericardial effusion, a non-dilated left ventricle with an ejection fraction of 30%, and mild mitral regurgitation. Endomyocardial biopsy shows lymphocytic myocarditis. Which of the following statements regarding this patient's prognosis and implications for therapy are true? So this picture is just telling us maybe a viral myocarditis with a short history, most likely a fulminant one, because the history from the onset of the viral infection to the myocarditis is actually short. So most times for any form of myocarditis, wherever the etiology, the best, because most times myocarditis are rapidly progressive, so the best treatment, even when you have immunosuppressant and anything, what they benefit from most time is if they can get a mechanical support and then cardiac transplantation. So as much as possible, that's the thing, mechanical circulatory support and cardiac transplantation. So I'm going to go through the option. Option A says its chance of survival is less than 10% without cardiac transplantation. Emergent transplant listing is warranted. Option B, its chance of survival is greater than 50% with many similar patients having a full recovery in left ventricular function over the ensuing weeks to months. Aggressive pharmacologic and mechanical hemodynamic support is warranted. Option C, immunosuppression with high-dose systemic steroid will increase its chance of survival. Option D, the presence and titer of anti-heart antibodies can help provide prognostic information for this patient. So for this patient, option D, I don't think that's the right answer. Option C, even like I said, even if you give high dose of systemic steroid, it doesn't still mean that it will increase their chance of survival. Most times they'll still be on mechanical circulatory support and will need heart transplant. Option B says his chance of survival is greater than 50%. No, it's not great with greater than 50% with only pharmacologic and mechanical circulatory support. Heart transplant is a cut thing in them. So option A, his chance of survival is less than 10% without cardiac transplantation. So I think this is the most correct answer. His chance is really limited unless he has a cardiac transplantation. Thank you. Contributions, comments, please. Okay. If there is none, I move to 102. You are evaluating a 42-year-old woman with a history of Hashimoto's thyroiditis many years ago, who was treated successfully with radioactive iodine. She presented to the emergency department after passing out at home and reports several days of worsening lethargy and chest discomfort. So she's short of breath with a resting heart rate of 110 beats per minute and blood pressure of some 7/2 millimeter of mercury. Her extremities are cool and she seems sleepy. Her whole blood lactate is elevated and urine output for the first 2 hours of her stay is minimal. On cardiac monitor, she repeatedly has salvos of non-sustained ventricular tachycardia. Echocardiogram reveals a left ventricular ejection fraction of 15%, and emergent endomyocardial biopsy shows diffuse granulomatous lesions surrounded by extensive inflammatory infiltrate. Your following is true regarding our diagnosis. Okay. Option A says most patients with this etiology of cardiomyopathy recover with supportive care. Option B, steroids are highly effective in treating this form of cardiomyopathy. Option C, the cause of this cardiomyopathy is there, often with rapid deterioration requiring urgent transplantation. Option D, while seen occasionally, ventricular tachyarrhythmias are rare in this disease. Option E, none of the above. Now, the picture that is painted here looks like a picture of a giant cell with the lesions and the biopsy result. Looks like giant cell myocarditis. And like I said before, any form of myocarditis, the definitive thing is that you try and get a heart transplant for them, because most times the course is usually very fast, rapid deterioration, and patient usually requires urgent transplantation. So here, I think the most correct option is option C. When seen, they usually have ventricular tachyarrhythmia, so it's not rare in them. And steroids are not as effective as that. It's just to try and get them on supportive care and transplants. Please, are there additional comments? Okay, 103. All of the following are associated with an elevated risk for development of cardiomyopathy during anthracycline chemotherapy, except A, concomitant chest radiation, B, high total anthracycline dose, C, pre-existing cardiac disease, D, trastuzumab administration, E, all of the above are treated with elevated risk of cardiomyopathy due to anthracyclines. So this one, they're asking about chemotherapy-induced cardiomyopathy, specifically anthracycline. I know Dr. Malade mentioned recently what is specific to anthracycline chemotherapy, that we can say valvular degeneration, and I think she said something like myofibrillary loss in the myocyte. That is distinct with anthracycline chemotherapy. So for all this, so what will make a patient on this to have increased risk of having a cardiomyopathy? If they've had chest radiation or if they are having chest radiation, it increases their chance of toxicity. If the dose given to them is high, it also increases the chance. Pre-existing cardiac disease increases the chance of them having cardiomyopathy. Trastuzumab administration, I think that too should actually increase their chance, because that's another chemo agent being added together. So option E, all of the above are treated with elevated risk of cardiomyopathy due to anthracycline. Okay, so what's the option here?
So the answer is
that's what I'm looking at.
okay. All right. Sorry. I thought you answered.
No, because I actually thought that all of them will be associated with the risk. So I thought all of
so
them.
the answer is E, because E says all of the above. It says all of the above will be associated with elevated risk.
Due to anthracycline. Well, maybe, yes, I'm thinking the answer is A, but since all the others too can predispose them to having that toxicity, so that means E2 should be right, or am I getting something wrong? Do you get what I'm saying, Dr. Tu?
I'm looking for the one that accepts.
I tend to be.
But I think that the trastuzumab accepting, they said the incidence with cardiotoxicity is lower than for anthracycline. So I don't know whether maybe that's the reason why they accepted so, because it means that concomitant test radiation is true, and the high total dose of anthracycline dose is also true. Then pre-existing cardiac disease is also true. So the D is not that for the trastuzumab administration. So there's a lower incidence of cardiotoxicity in relation to accepting.
If this
Yeah, but it's still part of it.
I think it's still part of it.
I think the answer to this question is likely E.
It's saying all of the above are associated with elevated risk. That means E is also true. So there's no answer here. There's no except.
So if I can make a comment, please.
All right.
Yes.
So for anthracycline and cardiotoxicity, it's usually a type 1, you have type 1, type 2, type 3, type 4, type 5 of cardiotoxicity. So anthracycline is type 1. It is irreversible and it's dose dependent. So the higher the dose, the more the cardiotoxicity. Although newer studies now are showing that even with low doses, we can still have cardiotoxicity. So it's dose dependent, it's irreversible and type 1. Trastuzumab, that's the type 2, is actually reversible and it is not dose dependent. So it's milder than anthracycline. The worst of them all is anthracycline. So we have 3, 4, 5. Let's not bother our heads about that. However, looking at this question now, when we have anthracycline toxicity is more in the presence of those having some other chemotherapy adjuncts with cyclophosphamide, with docetaxel, which are commonly used together with the anthracycline. It increases it. Most of the patients with breast CA, after they have had the first cycles with anthracyclines, they go ahead, for those who are HEPS2 positive, they go ahead to have trastuzumab. So when they have trastuzumab, it increases the risk of cardiotoxicity in them. So that means that's true. Then pre-existing cardiac disease, yes, it worsens cardiotoxicity and increases the risk of that. So all are actually are associated. So that's just it here. What Dr. Prince was saying, I try to understand is because the risk is lower than for anthracycline. But however, when used with anthracycline, it increases the risk of cardiotoxicity. Thank you.
Thank you very much for the contribution. So what's the answer here?
Answer is E.
E, all are true.
Yes.
But it has an except here. That's the
except
thing.
No, the answer is not you. Actually, I think the thing is that
Understand?
I think there's a mix up in this particular question.
Yeah.
That's
It
just
has
what
an
I see now.
yes.
Because everything here is actually correct. So where is the
That's
except? If the except was not there now, okay, it will go.
yes.
From all explanations now. That's what I think.
Okay. Can somebody help us check? Can we check the answer or but with what we've explained, everything is true.
Textbook made mistake now, so now don't jack book reach.
So should we continue to 104?
Go ahead, please.
Okay. Thank you so much for all the contribution. So question 104. Mr. Kia is a 32-year-old bass guitarist with no past medical history. He presents with chest pain after suffering coryza, cough, fever, and muscle aches for the past week. He described his pain as constant and relating to his left shoulder. It is exacerbated by lying flat and during deep breaths. Examination reveals a rasping extracardiac sound present in 3 components per heartbeat. That's friction rub, I should think. His ECG is pictured in Fig V104. Troponin high levels are undetectable on presentation and 6 hours later. Blood pressure, heart rate, and oxygenation are normal. What is the most appropriate next step? Okay, so with this clinical scenario.
Sorry, Dr. Deyanju. Sorry to take you back a little. I was a little bit. If we read that 103 option E, let's read it well. All of the above are associated with elevated risk of cardiomyopathy due to anthracycline, right? If we look through that statement clearly, some of them may not be due to anthracycline, like that statement, inherent in that statement is the answer. What that statement is trying to say is that if it's coming from anthracycline, so the statement itself has the devoid response. It doesn't portray. If they're saying all of the above are associated with elevated risk when associated with anthracycline, that means all the answers we bought. They are now trying to say they're relating it directly to the anthracycline. You can continue.
Okay, I think I can get the where you're coming from. They are trying to put all these risks ahead of anthracycline rather than together
Yes,
with. Is that what you are trying to explain, sir?
yes.
Okay, I get you. Thank you, sir. Okay, so it's question 104. Okay, so I think the clinical scenario they've painted there is that of pericarditis, thoracic chest pain, and friction rub, 3 cycles, troponin levels are normal. So looking at this ECG, there seems to be widespread ST elevation. In AVR, there is ST depression, obviously. And if you look at lead 2, we can see this codic, and we can see the TP depression, downsloping TP in lead 2. So I think this is pointing to acute pericarditis in this patient. So the option A, please can you kindly help me scroll up, sir? Option A says aspirin 81 milligram daily, metoprolol 25 milligram twice daily, and atorvastatin 80 milligram daily. Option B says aspirin 1 gram every 8 hours with omeprazole 20 milligram daily. Option C says heparin, aspirin, clopidogrel, and immediate coronary angiography. Option D says prednisolone 40 milligram daily for 2 weeks, followed by a taper over the ensuing 2 months. Option E says transthoracic echocardiography. So here they're just asking us that what would give a patient that has pericarditis that is confirmed. They've already done, okay, they've not done it, but transthoracic echocardiography might not be the best next step because the clinical picture is actually straightforward. Prednisolone 40 milligram daily for 2 weeks, followed by a taper down over the ensuing 2 months. No, that's not how we taper down. It's 2 weeks, but we can do 4-2-2. Then heparin, aspirin, clopidogrel, and immediate coronary angiography. That one is more in keeping with an MI. If you think the patient have an MI. Aspirin 1 gram every 8 hours with omeprazole 20 milligram daily. Okay. Option A, aspirin 81. So I think the most correct answer here might be option B, but we have to also remember that apart from giving our anti-inflammatory agent, as NSAID, aspirin, or colchicine altogether, we also need to remember that bed rest is very, very important in patients that have pericarditis, and also a gastroprotectant, a PPI, is also very, very important in their management and
Victor,
care.
Dr. Neil.
So I think the correct option here is option A, an NSAID with a PPI, but they could have added bed rest to it. Question 105. You are caring for a 45-year-old man in the cardiac intensive care unit. He presented with chest pain and initially was thought to have acute coronary syndrome, prompting initiation of antiplatelet agents and IV heparin. After complete assessment and the return of negative serial cardiac enzymes, it became clear that he instead had acute pericarditis. Shortly after admission to the cardiac intensive care unit, he becomes hypotensive with elevated neck veins. His lungs are clear to auscultation. His extremities are cool. And you note that his brachial pulse is only palpable during expiration. What is the most likely diagnosis? Now they've painted the picture of a cardiac tamponade here. So the options: option A, aortic dissection; B, cardiac tamponade; C, left main coronary artery occlusion; D, ruptured chordae tendineae; E, ventricular septal defect. So I think this patient currently has a cardiac tamponade, which is B. However, with the whole clinical picture of chest pain, then having something looking like a cardiac tamponade, it's possible that maybe the patient had an aortic dissection that is now tamponading. That's a possible explanation here. But the clinical history given here is cardiac tamponade. So I think the correct option is B here. Please, any contribution?
Sorry, did you say A or B?
I said B because what they gave, patient became hypotensive, have elevated neck veins. The brachial pulse palpable during expiration and not inspiration too. The picture is cardiac tamponade. I'm just trying to say that, okay, what could have led to the cardiac tamponade in this patient that came in with chest pain originally?
Maybe it's all these talks is all now. Antiplatelets.
What the anticoagulation that was given to that the IV heparin.
Yes, it's possible to that could have actually make him bleed. It's possible. Okay, so question 106. So you call for emergent echocardiography in the patient described in question V106. In this patient, which of the following is likely to be increased during inspiration compared to expiration? I think that they meant that from the patients above in 105 and non 106. So they're asking us about cardiac tamponade, which is likely to be increased during inspiration compared to expiration. Of course, during inspiration in cardiac tamponade, you know that there will be increased inflow to the right side of the heart during inspiration. And then for the left side, there will not be enough blood going there until maybe about 3 cardiac cycles or more before the left ventricle can actually have enough volume to be able to expand a little. So for option A, it says that the left ventricular end diastolic diameter will be increased. No, it will be reduced. The left ventricular stroke volume, no, it will be reduced because the volume of blood going there is actually small. So the stroke volume will be really low. And this is what gives us the reduced blood pressure, hypotension in them. C says the mitral inflow velocity, no, this will be reduced. The systolic blood pressure, the stroke volume, systolic blood pressure, cardiac outputs, everything will be reduced. Then E says the tricuspid inflow velocity. Yes, the inflow on the right side will actually be much at onset of so I think the correct option here is E. Yes. Please, any contribution?
Okay, I want to ask a question. Is I think a patient that has aortic dissection can still have myocardial infarction.
Yes.
It's possible, right?
Yes.
So how do we now differentiate it now in this scenario? How do we differentiate it in this question above now? Like, the patient came in and they gave anticoagulant and all that. What if the patient presented with aortic dissection and then ST elevation? Something that corresponds with ischemia.
Although I can't
You understand what I mean?
and try and think of what you are trying to say, sir. If you look at the previous question, they talked myocardial infarction that the patient had. So they quickly gave antiplatelet, anticoagulant, but they said it's too. One of the things that made them to differentiate, although they based their investigations on the cardiac troponins, which is actually one of the things that needs to be done according to the guideline. Troponins, it was normal, but for us at the emergency, aortic dissection, MI, we have to start from the history, the characterization of the pains. Most times, the pain for AD is tearing related to the back, although MI can also present that way. Also, when the AD, if it's involving the arc of the aorta and it involves the coronary vessels, they can come with symptoms of MI in these patients. But I think that going forward, the cardiac biomarkers, they are also elevated in aortic dissection, but not as high as if it's a myocardial infarction. So going forward for that kind of scenario, I think the investigations that will be done will actually help out. Apart from your from the ECG, echo, maybe going higher to do a CT aortography too might actually help us in this clinical scenario to be able to differentiate between whether it's MI or AD. But as you've rightly said, sir, AD patients can have MI because of the, depending on the site that is affected, if it's affecting the arc of the aorta where the brachiocephalic, carotid, common carotid and subclavian, those that give a branch to the coronary vessels, if they are affected, they can come with MI. So I think that it depends. We'll be able to argue our way out, yeah, if they bring something like that. That's my thought. I don't know if
I can make a comment too.
Please go ahead, ma.
Yes.
Thank you.
Thank you. Thank you so much. To differentiate the aortic dissection that will cause an acute coronary syndrome will be affecting the corpse either the right or the left. And when that happens, there will be affectation and patients will actually have like a regurgitation and the lungs will not be clear in that instance. So here they are telling us that there's nothing wrong with there's no pulmonary edema. The lungs are clear. So only giving us features of like a plethora. They described also substance here. So it's tending towards the right. So the thing that will cause aortic dissection together with MI will be taking all those cups. And when it takes those cups, it will cause a regurgitation. Regurgitation will cause acute left ventricular dysfunction, which will cause acute pulmonary edema, which is not in this patient. So it means that from the RVOT or even from the right ventricle to there's nothing in the pulmonary system. It's clean. So we don't expect to see that in aortic dissection with coronary disease or coronary affectation. The same goes for, we are thinking of an MI with mitral regurgitation. There will be backflow definitely to the lungs. So when you don't see that, just take your eyes off that. It's not on that side, it's on the other side. So you now try to differentiate between, depending on what they are describing to us now. Is it a right ventricular infarction or is it a tamponade, like she has said? So when they are now giving us things like pulsus paradoxus, and they are just giving us clear destiny to help us to narrow what's actually the problem is on the right. Thank you.
Thank you very much, Dr. Molade. Chief Agu, is it?
Thank you very much. Yeah, thank you. Thank you.
Okay, thank you, sir. So question 107, please. Chief Itsubi. Okay, thank you. All of the following ECG characteristics will aid in differentiating, I think all this thing is just pericarditis. All of the following ECG characteristics will aid in differentiating acute pericarditis from acute MI, except option A, absence of the development of Q waves. Option B, concave shape to ST elevation. Option C, PR depression. That will always be in, I think, in V1 and AVR. Option D, ST elevation in V2. Option E, T-wave inversion after return of the ST segment to baseline. I think that we've seen this question in maybe in one of the recalls or in Prof's book. So they are just trying to ask about the phases of pericarditis here and how we'll be able to differentiate this from MI. So the odd one out here is ST elevation in V2. If you have an ST elevation in V2, you might be pointing to a possible MI. If you have an ECG and there is absence of development of Q waves signifies maybe hold MI or thereabouts. If it's not there, so it's telling that it might be pericarditis. Concave shape ST elevation, widespread pericarditis, PR depression in V1 AVL, most likely pericarditis. T-wave inversion after return of the ST segment to baseline. That's also part of the cycle, part of the stages rather of acute pericarditis. As we know that the first week we have concave shape elevation of the ST segment, widespread. Is followed by flattened T-wave, then inverted T-wave, then normalization of the ST and T-wave. Those are the phases of acute pericarditis. So I think this is the correct answer here. Is the except correct answer here. Please, any comment? Okay, I move on. Question 108. A 35-year-old woman is admitted to the hospital with malaise, weight gain, increasing abdominal gas, and edema. The symptoms began about 3 months ago and gradually progressed. The patient reports an increase in waist size of 15 cm. The swelling in her legs has gotten increasingly worse, such that she now feels at times as swollen as well. She has dyspnea on exertion and two pillow orthopnea. She has a past history of Hodgkin disease diagnosed at the age of 18. She was treated at the time with chemotherapy and mediastinal irradiation. On physical examination, she has temporal wasting and appears chronically ill. Her current weight is 96 kg, an increase of 11 kg over the past 3 months. Her vital signs are normal. Her jugular venous pressure is 16 cm, that's elevated. And the neck veins do not collapse on inspiration. Heart sound at distance, okay? There is a third heart sound heard shortly after aortic valve closure. The sound is short and hard-blunt and is best heard at the apex. The liver is enlarged and pulsatile. Ascites is present. There is pitting pedal edema extending throughout the lower extremities and onto the abdominal wall. Echocardiogram shows pericardial thickening, dilatation of the inferior vena cava and hepatic veins, and aberrant cessation of ventricular filling in early diastole. Ejection fraction is 65%. What is the best approach for the treatment of this patient? Yeah, so this patient have many comorbidities. Has background Hodgkin's lymphoma that was managed with chemotherapy, mediastinal irradiation. She has features of heart failure. She also have features of pericarditis, and the heart sound at distance. And okay, pericarditis, they did not say whether she's tamponading right now. However, the liver is also congested. So with the echocardiogram showing pericardial thickening and the old picture that they've given here, I will be thinking that this patient have and because of the prior history of maybe radiation therapy and everything, I think that she has some form of pericarditis, most likely constrictive pericarditis from the radiation that she had had. So if that is the case, that was the best approach for pericarditis. So looking at the option A says aggressive diuresis only. They only even negate it, so that's false. Cardiac transplantation, I'm not sure that she's at that stage yet. Ejection fraction is preserved. So she's not there yet. So that's stage B. She might still benefit from medical management. Option C, mitral valve replacement. There is no indication for that here, so that's wrong. Option D, pericardial resection. I will leave that one. Option E, pericardiocentesis. Okay, so right now there's nothing saying that she's tamponading, but definitely she has pericardial effusion. So I would rather go for option D, pericardial resection, because of the echocardiogram appearance of pericardial thickening. Most like maybe she has constrictive pericarditis, and she might need to go for surgery for pericardial resection and maybe creating a window to allow expansion of the heart. So maybe that will help her. Then apart from that too, then one needs to optimize therapy to take care of the congestion that she has, and also to manage the background comorbidity in this patient. So I will be thinking that the pericardial resection of the pericardial thickening and it will actually benefit more. So I think the answer here is D. Question 109. If there are no comments or contribution. 109. Okay. Okay, a 45-year-old accountant past medical history has experienced occasional fevers, symmetric arthralgias, and fatigue for the past 3 months. So experienced the sudden onset of left hand weakness, which resolved within 1 hour. Multiple blood cultures have been negative. Emergent at our local emergency department included the HCT that was unrevealing. Last week, she had a transthoracic echocardiography that showed 2 cm mass in the left atrium arising from the interatrial septum in the vicinity of the fossa ovalis that are populated vascular stock. We are seeing her back in clinic today. What is the most appropriate next step? Okay, so this is just so classical. You can remember our lecture from Dr. Mulade's lecture. She talked about where the commonest early mass is. The commonest myxoma is rather, that's in the early. And she actually made mention of interatrial septum, fossa ovalis, and pedunculated stock. So I think that these patients have a left atrial myxoma, and like she said, and it's presenting like part of complications that you can have. You can present with stroke if it's embolizing or anything, and you can have an MR murmur in this patient. A plop can be heard if you listen at the apex. So I think that maybe she has an embolic event that made her have a sudden onset of left hand weakness, which resolved. Apart from that, Dr. Mali also mentioned that you can have systemic symptoms. So I think this is classical for an from a mass. And from that lecture, she said that the best thing is just surgical removal of everything. So looking at the option A says cardiothoracic surgical removal of the mass. B, catheter-based biopsy of the mass. There's something we are biopsying here. Repeat blood cultures and inform the microbiology laboratory to place on special media to evaluate for ASEC organisms. There is no reason for that. Serologies for ANA, anti-DNA, and anti-cardiolipin antibodies. That's just a waste of time. We know what is causing what we have already. Option E, whole body PET scan to evaluate for malignancy. So that won't be the first thing to do. So I think the most appropriate next step here is option A, the cardiothoracic surgical removal of the early mass. I think it's straightforward. Question 110.
Sorry, and of course, occurring on the left atrium means that it's most likely benign, right?
Yes, it's a benign tumor, sir.
Thank you.
Thank you, sir. Question 110. Which of the following malignancies carries the highest relative risk of metastasis to the heart? A, glioblastoma, B, hepatocellular carcinoma, C, is melanoma, C, malignant melanoma, D, pancreatic adenocarcinoma, E, small cell lung cancer. The correct answer is C, malignant melanoma. If we can recall, this question is also in Prof's book and in Brownwood. And I think it's in one of our recall. So the correct option here is malignant melanoma. So thank you so much. That brings us to the end of my aspect of the so I don't know the next person. Are there comments or contribution, please? Okay. So I think Dr. Itsubi, please can we go to, I think Dr. Prince should be the next person if I'm right. No, Dr. Prince is taking 160 to 167. Chief examiner, you know the next person, sir.
I don't know, we can't hear Dr. Philomena. She's still on the call.
Yeah, I think 161 to 167 now.
Okay, thank you, Dr. Prince. Dr. Philomena, are you still on the call? Hello, Dr. Philomena, ma?
I am, but please, it seems I made some mistake. You know, you told me 91 to 100.
Yes, ma'am.
I was solving one, I think section 1 or so.
Okay.
91 to 100. It was when we started this evening, I noticed that I was solving that in error. That was what happened.
There's no problem, ma'am.
So Can I still do it tomorrow, or are you giving me another number?
We'll do it tonight, but the people that are prepared, then we'll come back to it. This is the last part that we'll take together, if it's okay with you.
I didn't get you.
You said that you are not prepared for it, right?
I was solving 91. They were talking about bioterrorism. I was wondering how that was related to this thing until this evening. That was when I now knew that it was in another section that we were.
Okay. If it's possible that you start and if you've gotten the so at the end of the day, we'll look at it together.
Okay. Okay.
Thank you very much.
Okay.
Chief Etubi, I don't know this person now. Somebody's supposed to take one. Okay. Dr. Prince is 161 to 167.
Dr. Prince is ready. Let me take his on.
Okay.
Then Dr. Nyebo is there. Then we'll
Okay.
get back to the last part.
Okay. Thank you so much. Dr. Prince, sir, over to you.
Yeah, so question number 161. It reads, a 37-year-old woman with no past medical history except for a childhood memoir is evaluated for sudden onset of severe pain in her right lower extremity. Examination is notable for a young, uncomfortable woman with normal vital signs, except for a heart rate of 110 beats per minute. The right leg has pallor, distal to the right knee, and is cool to touch, and the dorsalis pedis pulse is absent. The left leg is normal. Which of the following studies is likely to diagnose the underlying reason for the patient presentation? So this is a 37-year-old, no history of any past medical history. He just gets a sudden onset of what looks like peripheral arterial occlusive disease, because so as evidenced by the absence of the dorsalis pedis. But the examination also mentions the fact that this woman appears uncomfortable, but however with normal vital signs. And we are further told that the extremities are cold, which further points to the peripheral arterial disease, and there is also evidence of pallor and all that. The other things that we will need to evaluate in this patient. So the question was, which of the following studies likely to diagnose the underlying reason for the patient presentation? So if it's peripheral artery disease, we're expecting that this is a 37-year-old. There should be significant history of risk factors that will predispose her to that, from diabetes, hypertension, from the use of oral contraceptives and all that. We are not given that much history per what we have now. So since it's so clear, because there's occlusion, if we do an angiography of the right lower extremity, it's just only going to confirm the fact that there is occlusion of the blood vessel and arterial supply, and for that matter, peripheral artery disease. It's not going to diagnose the underlying reason for the patient's presentation, but we are going to confirm the fact that this patient has a PAD, but it won't give us the reason, the underlying disease disorder, whether the patient has maybe a familial hyperlipidemia, the patient has like multiple thrombotic disease, has some hypercoagulable disorder, anything. We will not be able to tell. Then blood cultures, there is no evidence of fever. We don't have any fever. We don't have any chills. So blood cultures is also very unlikely to tell us anything. Then if you look at C, it's echocardiogram with bubble study, which could be possible because we have a patient who is 37 years old and is a woman who is also in the childbearing age as well, still within it. And so if possible, the patient may have a paradoxical emboli that might have might have been thrown arterially, and that might be the reason for the presentation, because there was a childhood memory So as they age on, really over time, as they age on, there could be a right to left shunt. In fact, if it's an ASD, then you could have a right to left shunt, as it were, with time from the age, or a PFO, patent foramen valley. So in the absence of a right to left shunt, the most likely one would be a PFO in this context. So the answer will most likely be the echocardiogram with bubble study. Venous ultrasound of the right upper extremity will not show much because we are talking more of arterial. And the DS, the cytoplasmic anti-neutrophil cytoplasmic antibody, that's the C anchor. And the C anchor, as we know, has no role with peripheral artery disease. The C anchor usually has to do with the C anchor is in which conditions actually have even have C anchor? I'm just forgetting now.
You know this polyangiitis, what do they call it?
Exactly.
All
Yes.
those,
The
yeah,
small.
Yeah,
yeah,
the vasculitis.
vasculitis, yes, small vessel, small to medium vessel.
Yes.
Yes. Okay. All right. So yes. So polyangiitis, granulomatosis with polyangiitis. That's what I wanted to remember. Granulomatosis with polyangiitis. Okay. Or Wegenous granulomatosis. Okay, so that's the C anchor. So that's also very unlikely. So the answer looks like echocardiogram with bubble study. So the patient might have shown an emboli that might have gone into the arterial system. So I'm thinking that the patient may have a large patent foramen valley or may have an atrial septal defect, which can be demonstrated on a bubble study. Question number 162. A 32-year-old construction foreman presents with exertional pain in the bilateral forearms and then hands. Presents with exertional pain in bilateral forearms, in his bilateral forearms and hands. He smokes 1 pack of cigarette per day, but otherwise has no medical history. He has an easily palpable brachial port, but very faint radial and ulnar pulses. A picture of his hand is shown in the figure below. Angiography of his upper extremity reveals smooth tapering segmental lesions in the small distal arterial vessels. Angiography of his upper extremity reveals smooth tapering segmental lesions in the small distal arterial vessels, which are the function that has the greatest chance of success. So I think we can see the hand is there. And if we look at it, the patient has evidence of vaso-occlusive disorder involving the small and medium vessels in the distal, upper, and lower extremities. So this in the distal upper extremities. So this most likely in the patient who smokes, and judging by the age, the patient is also 38, as it were. So we may be dealing with a case of probable thromboangiitis orbitans or Breger's disease, which is closely related to vaso-occlusive disorders and diseases. So if you look at the interventions to help, and in Breger's, because it's more of a vasculitis or vaso-occlusive disease involving the small and medium-sized arteries. Sometimes they may have cerebral, visceral, coronary vessels as well, but they are rarely affected. But mostly the extremities are the ones that are mostly implicated, especially the upper and lower extremities. And then sometimes they may have associated intermittent claudication when the lower extremities are involved. Then the Raynaud phenomenon, which we can see in the figure, and they'll have migrating superficial vein thrombophlebitis as well. So it's not only arterial, it also involves the veins as well. And we need to remember that it's venous and arterial. So the triad is that of Raynaud phenomenon, migrating superficial vein thrombophlebitis, and then claudication of the affected extremity. And mostly either is if the exertional pain is in the upper limbs, intermittent claudication, the lower limbs, as it were. So there is no specific therapy for it. Anticoagulation has not been shown to be evident in terms of evidence to help, as well as prednisolone. And likewise with flustazole, which help in novel peripheral artery disease, it doesn't really help that much in patients with thromboangiitis orbitans. So the answer is D, smoke cessation. So usually you advise them to stop smoking at the risk factors, which we've already mentioned, and one of them is smoking. It's closely related to smoking as well. So you need to tell the patient to stop smoking. So that is the answer. All the rest, there is no evidence it helps. 163. Which of the following statements regarding chronic venous disease is true? Okay, so more men than women suffer from varicose veins. We know that is false. Varicose veins is more common in women. Okay, then B, more men than women suffer from chronic venous insufficiency with edema. So even though more women suffer from varicose veins, chronic venous insufficiency appears to be the opposite. So chronic venous insufficiency is rather more common in men than women, but varicose veins tends to be more common in women. So usually if you can see, we'll see some of our relatives with all these varicose veins. Most of them, you realize that they are women. But then for the chronic venous insufficiency, that is in men. So the answer is B. Then the C said that more than 50% of patients over 70 years old have chronic venous insufficiency. So the percentage is lower because the incidence of all this is about 7%. So it can't be 50%. The chronic venous insufficiency is about 7%. So more than 50% is just way off. So it's not true. Most patients with chronic venous insufficiency will develop venous ulcers. So it's not most, it's some of them. So, and it's less than 50%. So they approximated it to around 20%. So it's untrue. All the above are true, which is false. So the answer is B. So it's more men with chronic venous insufficiency. And then 164, I think this is anatomy, which...
Hello, Prince.
Yes.
I don't know if you equally came across the reasons as to why, even though that men have more varicose veins, but the insufficiency with edema is more in women. Did you come? You can hazard as to why?
Okay, so I didn't really come across any particular reason that with why they said that basically there is, it's unclear. I mean, there are variable school of thoughts. The only thing is that they came across these figures based upon data. So there is no particular reason why men tend to develop chronic venous insufficiency, even though varicose veins tends to be more common in women. So it's not clear. So far, there is nothing really out there as to why. But what they mention is that based upon the data that they have, it appears that chronic venous insufficiency is rather more common in men as opposed to women.
Thank you.
So 164. Which of the following is the longest vein in the body? So I think this one was more of a fact question and all that. So per my reading, they said the greater saphenous vein is the longest vein in the body. So they mentioned the zygous vein, the inferior vena cava, left common iliac vein, right common iliac vein, but the B, the greater saphenous vein. So I think there was something that I think basically that was it. So they said it's the longest. They didn't get. I've not seen the measurement because they said it's variable from people, but generally, it's the longest vein in the body. And I presume that because of, they said the great saphenous vein is the longest vein in the body. It originates on the medial side of the foot and ascends anterior to the medial malleolus and then along the medial side of the calf and thigh. So it goes all the way from the foot, goes through all the way on the legs, on the medial side of the thigh, and drains into the common femoral vein. So I presume that if you look at the stretch, that's from the foot, the medial malleolus, medial side of the leg, then the thigh. Probably that may account for the reason why it's long, as opposed to the greater the zygous vein, which is around the esophagus, and it appears to be a very short vein. Then the inferior vena cava too, if you look at the length from the liver to the right atrium, it's subsequently we may be able to appreciate the fact that it will not be long as well compared to the greater saphenous vein and the left common iliac veins. Okay, question number 165. You are evaluating a 77-year-old woman from Ohio with a history of heart failure with preserved ejection fraction, diabetes mellitus, and a prior left lower extremity deep venous thrombosis, and a prior left lower extremity deep venous thrombosis status was the cause of anticoagulation. For the past several months, she has complained of cramping, burning sensation of her legs. Today, she presents with evaluation of skin ulcer pictured below. On examination, you know that the skin ulceration over the medial malleolus and a non-pitting wound-type edema of the bilateral ankles and shins. The skin here is darker as well. The ulcer is most likely due to which of the following? So the options are arachnid envenomization. We don't have any evidence of arachnid bites and all that, so I think that is very unlikely. And then Bacillus anthracis infection, the symptoms that we've been given is not in keeping with Bacillus anthracis infection. Then we have chronic venous ulcer, which which could be possible. Then he has a diabetic foot ulcer, which could also be possible. Then he has peripheral arterial disease. So from what we have from the history, we have evidence of left DVT, which is on anticoagulation, but we are also presented with a case of non-pitting wood-type edema of the bilateral ankles up to the shin. And if it's the left, there was no cause for there to be an involvement of the right, but we have right lower limb or right ankle edema as well. So it's not only the left, but we are told about the DVT on the left. And then it has the classical wood type non-pitting edema, which says that the edema has been long-standing or has been there for a long time. Typically, if we are thinking diabetes mellitus and with the risk of diabetes mellitus and possible peripheral artery disease, arterial ulcers at the extremities. So maybe we'll see that there will be evidence of gangrenity on the toes, but it will not be at where we see the ulcer as it stands now. If you can see the ulcer and you can see the area around the ulcer and the skin changes, which suggests that because of the edema or the stasis and all that. So judging by the peripheral artery disease is also very unlikely. And then diabetic foot ulcer most likely would also go through the pathway of mostly the peripheral artery disease. So it looks as if that this is most likely the C, which is a venous ulcer. Patients may have an underlying chronic venous insufficiency because of the fact that even though the DVT is on the left, he has swelling of both limbs, which has been long-standing, and then we've not been told about the patient has a preserved ejection fraction and all that, and the patient otherwise have been fine, and it's on anticoagulation. So I think that, and we know that heart failure in itself is also a risk factor for chronic venous insufficiency as well because of the long-standing edema that it comes with it. So it may predispose a patient to it as well. So I think that it's more of a venous ulcer. So the answer is C. (166). You are evaluating a 19-year-old woman in a travel clinic at your university. She complains of a non-painful swelling of the lower extremity. On examination, the leg has thickened skin and a woody texture. A bedside ultrasound confirms patent lower extremity veins without thrombus. You suspect lymphedema and think that is likely to be the most common cause of secondary lymphedema worldwide. What do you expect? So this is a non-patent swelling of the lower extremity, so possibly a lymphedema. And then there is no evidence of DVT. So you are being told that is the most common cause of secondary lymphedema worldwide. So what do we expect? So cancer involving the inguinal lymph node, which is not so, because it's not the commonest cause. And then we have lymphogranuloma venereum, that's LGV, which can do that. But from the literature, that's not the commonest. In the literature, the commonest cause is lymphatic filariasis, and then after lymphatic filariasis, then you can also have other infections like the LGB and tuberculosis. So it's lymphatic filariasis, tuberculosis, LGB, and all that. So recurrent bacterial lymphangitis, it's very unlikely. It's not that common. The instances, though, apparently they've not even been able to actually give the actual incidence for that because it's so low. They don't have adequate data on recurrent bacterial lymphangitis. And then cancer involving the lymph nodes, if there's a lymphoma, typically lymphomas may not really be associated with classical lymphedema because there may not be any significant obstruction at all. probably because of the lymphoid cells that undergo transformation and then proliferation. So the answer of 166 is C, lymphatic filariasis, and that is a fact. 167. You are taking care of a patient who suffers from chronic lymphedema due to recurrent streptococcal lymphangitis as a child. She finds her leg swelling on site and asks our therapeutic options. All the following are reasonable therapeutic options for chronic lymphedema. So the first answer is decongestive physiotherapy, which is true. So basically, it's massage therapy and all that. That's decongestive physiotherapy. So anything that will help in terms of muscle contraction and help. So decongestive physiotherapy includes walking, exercise, and massage therapy and all that is true. So that's a true option. Then diuretic therapy, I will leave that one for now. And then we have frequent leg elevation. That's actually one of the non-pharmacological ways in order to get the swelling down. You elevate the leg on a pillow, sometimes ideally whilst asleep. Then D, the intermittent pneumatic compression device, which is true. And it's the only one that has also shown some evidence of prevention of DVTs as well. Then the E was liposuction. That's something that I had not really come across before, but so the diuretic therapy, all I know is that in lymphedema, typically you don't want to put the patient on diuretic therapy because the underlying pathophysiology is not because of volume overload from maybe cardiac issues or from liver cirrhosis or some sort. So usually it's they advise against the use of diuretic therapy because of the risk of electrolyte abnormalities, and that can also because of the extravasation of intravascular volume into the interstitial space in patients with lymphedema. Giving diuretic therapy may also subsequently not decrease the intravascular volume further. So typically, you don't really give diuretic therapy. So the answer appears to be B.
Okay. Thank you so much, Dr. Prince, for that very lucid discussion. I just want to go through the chat box. Okay, Dr. Lalekon is asking that why is the answer not peripheral arterial disease? I think that should be for that leg ulcer, I should think.
Yes, so I was saying that with peripheral, even though the patient is diabetic, the ulcer appears not typically, it's supposed to be there, it's spared the extremities, and rather it's on top of the bone if you look at the location of the ulcer and all that. So if you look at it, and it appears a bit reddened and fresh, and typically arterial ulcers, you expect it to be very dry and sometimes even gangrenous and all that, even though sometimes it can do the wet, but most often you expect a more dry wound or ulcer. And then it prefers the extremities like the toes and all that in this particular patient. And then typically in peripheral artery disease, you typically wouldn't expect the patient to have the edema that the patient has been getting. We're given a prodrome of, we are given a preamble of a patient with heart failure with preserved ejection fraction. So the congestion, the volume overload, and all that will predispose the patient to chronic venous insufficiency. And then subsequently, so that appears to be the likely answer, unless the patient were given bilateral swelling. So even assuming that we decide to typically decide not to even consider the fact that the patient has underlying heart failure, the volume overload and all that predisposing to venous insufficiency and all that. The patient has already a DVT on the left. Okay, the patient has a DVT on the left. And then we are told that the patient has bilateral ankle swelling which has been probably long-standing. And in that context, if it's peripheral artery disease, are we looking at it? You may be looking at it in the context of the DVT may be compressed on the artery in the context of phlegmasia, ceruleo dolens, where you have the DVT or the deep vein thrombosis compressed on the artery and then causing a peripheral artery disease. And in that case, we're expected to be in that same leg. Or the presentation, we didn't expect swelling in the other leg as well, but we are giving the patient with bilateral swelling and then an ulcer on one. So if you look at it, it's most likely it's a venous ulcer. Based upon the scenario that we've been given. It's not that it's impossible to be a peripheral artery disease, but I mean, the scenario and what we've been given here, between the two, you go for a chronic venous insufficiency than peripheral artery disease.
Okay, thank
That's
you very
my
much.
thought, yeah.
Yes, and from the chat box, Dr. Ruki is telling us again that peripheral arterial disease usually appears on friction or pressure areas. So those are the big toes and all the pressure areas of the leg. And they are dry with some changes of reduced perfusion, like airless, shining skin. So because of reduced perfusion in those extremities, they are shiny, airless, all those things that we check for when we are examining the legs. So thank you very much, sirs. Chief Examiner, sir.
Hello.
Yes, sir. You are welcome, sir. We are ready for you, sir. Thank you very much.
Because we have to finish it today.
Yes,
I didn't have chance to go through it, but then we'll do it together. We'll be going through it so that we'll finish it.
Whatever you say, sir, you are the chief examiner, sir. We are with you. Thank you.
Let's go through it. That was 131. Okay. Question 131. You are performing a diagnostic coronary angiography on Mr. Hayes. On the initial angiographic pictures, his arteries are clear of any obstructive disease. However, during a selective angiogram of the left anterior descending artery, we notice that a thrombus has formed on the tip of your catheter. During dye injection, the thrombus embolizes down the left anterior descending coronary artery, causing complete obstruction to flow. Fortunately, you are able to remove the thrombus with suction thrombectomy almost immediately. If you had not been able to remove the thrombus, when would you folks have expected detectable CKMB isoform in a standard serum assay? Option A is 5 to 10 minutes. Option B is 1 to 2 minutes. Option C is 4 to 8 hours. Option D is 12 to 24 hours. And option E is 24 to 48 hours. Well, usually CKMB rises within 4 to 8 hours and generally returns by 48 to 72 hours. The cardiac troponin, by way of background, also have a similar time frame for rise, but they last much longer, about 7 to 10 days after ST elevation myocardial infarction. So if we have this at the back of our mind and go through the options, we'll be able to see that A is not the correct answer because we are looking at when we will first have the first when we will first detect the first AKMB isoform in the standard serum assay. B, 1 to 2 hours is not also correct. And D, 12 to 24 hours is not also correct. E, 24 to 72 hours, that's even when we should be expecting it to return to normal. So the correct answer here is C, 4 to 8 hours. Let's go to question 132. Question 132. The
Sorry,
greatest...
sorry, Chief Onyebeze,
Yes,
if it
sir.
takes about 4 to 12 hours for the cardiac enzymes to be assayed, will the symptoms develop immediately, or will the symptoms equally wait for that long before it develops? Or does it mean that the cardiac enzymes lag behind the symptoms?
Okay, or does it also mean that the cardiac enzymes appear before the symptoms?
Or before the symptoms? I don't know.
Okay.
I don't know is equally an answer, so we'll go and check. I was just being curious.
Yes, what you just also said, we'll look it up. I didn't,
All right.
just as
All
I
right.
said, I didn't go through.
All right, sir. Thank you, sir.
Okay. Let's go through question 132. The greatest delay between symptom onsets and definitive therapy for patients with ST elevation myocardial infarction usually occur in what time interval? So the greatest delay between symptom onsets and definitive therapy. They're asking for what time interval that usually occur. First, A, between onset of pain and patient's decision to call for help. B, between patient's call and emergency medical team arrival. C, between emergency medical team arrival and arrival at the hospital. D, between arrival at the hospital and decision to initiate drip perfusion therapy. E, between decision to initiate reperfusion therapy and the actual initiation of this therapy. Well, if we look at the background, using the guideline and where every system is operated and working very normally, applying the standard protocol and universal gold standard, you will find out that option E, D, C, and B are all regulated and regimented programs or regimented time intervals, not to the time intervals. The only one that is a little bit not regimented, not given a time interval is, of course, the time the patient realizes that he's in serious pain and the time he makes up his mind to call for help. That's where we have the greatest lag of time that will delay treatment. So that greatest delay between onset and definitive therapy is actually between the onset of pain and the patient's decision to call for help. And this is actually most of the time where most of the out of the hospital deaths from ST elevation myocardial infarction do occur. Because by the time the patient makes up their mind to come to the hospital, most of them might actually, some of them, not most of them, might have actually been going to death on arrival. So the answer to question 132 is A. So that's part of the reason why we have many brought in dead, BID. Question 133. All of the following medications used in the acute management of ST segments inhibition myocardial infarction appropriately matched to their mechanism effect, except A, aspirin, reduction in thrombosen A, B, abscizumab, inhibition of the glycoprotein 2B3A receptor, C, beta adrenergic antagonist, reduce myocardial oxygen consumption, D, clopidogrel, inhibition of the platelets adenosine diphosphate receptor, E, nitroglycerin, reduce cardiac afterload. Well, E here, from what we've discussed previously, nitroglycerin is a dilator, coronary vasodilator, and would rather reduce preload. So it's not appropriately matched very well here. The rest, aspirin reduces the thrombosin A2 with the cyclosin.
Please examine yourself.
Yes, please.
Okay. Can we continue, sir?
Okay, okay.
Thank you.
All right, thank you. 134. A 61-year-old man presented to the emergency department 2 hours ago with angina, chest pain, and ST elevations in mid-1 AVL and V1 to V3, already localizing where the portion of the heart that is affected. At the time, the interventional cardiologist on call was involved in at that time, the interventional cardiologist on call was involved in a complex case and was unable to take the patient for prompt primary PCI. Thus, tissue plasminogen activator was administered. However, 120 minutes after administration of the tissue plasminogen activator, the patient continues to complain of chest pain and his ECG shows no resolution of ST segment elevation. What is the next most appropriate step? Administer a second dose of tissue plasminogen activator. B, administer streptokinase 1.5 million units over 1 hour. C, proceed with urgent coronary artery bypass grafting. D, proceed with urgent percutaneous coronary intervention. E, wait for 60 more minutes before pursuing any other therapeutic goal. Well, as a background, this patient has the evidence of failure of reperfusion with the fibrinolytic agents that has been given to these patients. And of course, we know that persistent chest pain and this segment elevation that is lasting for more than 90 minutes after we show that reperfusion failure. In this case, now that we are dealing with that, we'll be able to understand that a rescue reperfusion coronary intervention should be pursued because if we re-administer
Oh, Chief Examiner. I can't hear
Yeah,
you.
also president. So with this background, option A will not be the best thing to do because of the risk of bleeding. The same thing with option B. Of course, option C is also out of the options. I think this is also guideline treatment option. And the most valid option here is to proceed with urgent percutaneous coronary intervention, which is the correct answer. Option E, which is wait for 60 minutes before pursuing any other therapeutic option, is also a dangerous delay for this patient. What would have been affect option D is the availability of the interventional cardiologist. Because even if um, you've done that and then the interventional cardiologist is available 3 hours, that's when the option D will be followed. But the correct option here is option D.
Next question, sir. Thank you.
Okay. 135. Mr. Cooper underwent a tissue plasminogen activator administration, package ST elevation myocardial infarction 1 hour previously.
Chief
We had
Examiner.
an excellent. Hello.
Yes, sir. Your network is wavering. So I don't know. But
Can you hear me better now?
Yes, we can hear you now, sir. Or I can
Okay.
hear you now.
Okay. Can you hear me now? Hello.
Yes, yes, yes.
Okay. So I read again. Question number 135. Mr. Cooper underwent a TPA administration for acute STEMI 1 hour previously. He had an excellent response with resolution of his ST segment elevation and chest pain. However, the nurse pages you to evaluate a change in his rhythm. You note a wide, complex ventricular rhythm with a rate of 75 beats per minute. Mr. Cooper continues to feel well without new symptoms, and his blood pressure is 120/80. The next most appropriate therapeutic maneuver is which of the following? And then we had evaluated something like this previously when we talked of the idioventricular rhythm. And this is also what we are seeing here. It has been represented in a different form. And that was the question that I talked about the medical students also asking, if I may remember. So this patient is having an idioventricular reading. From what was explained, the wide complex ventricular rhythm that has been shown, and then the rate is at 75 beats per minute. Now, if we look at the options here, administer amiodarone at 150 milligram IV over 10 minutes. That's not the best thing to do here. Administer flecainide, no. Administer metoprolol, no. Carotid sinus massage, no. So going by the same answer that we had there, so continued observation will be the most correct answer.
Perfect. 136.
So 136, okay. An 84-year-old woman with a history of diabetes and hyperlipidemia presented to the emergency department 3 weeks ago with an ST segment elevation myocardial infarction. She underwent an emergent primary PCI for an acutely occluded left anterior descending artery. A 3.5 by 24 millimeter everolimus eluting stent was drug-eluting stent was placed with excellent angiographic results and complete resolution of his symptoms. She's been feeling excellent since then. Her discharge medications were metoprolol, aspirin, clopidogrel, rosuvastatin, lisinopril, and sliding scale insulin. She recently went to see her ophthalmologist who noted a right eye cataract. The ophthalmologist has contacted your office asking about your opinion on discontinuing her aspirin and clopidogrel to reduce bleeding risk during cataract surgery. Which has been scheduled for next week. She feels the bleeding risk on both medications is too high to perform the surgery. Which of the following should you recommend for this patient? Now, first of all, this patient had an MRI, ST elevation MRI, and has been reperfused and is on treatment. So it's a case of weighing the odds against each other. She has a cataract, and as far as we are concerned, the heart is at more risk than the cataract surgery, which is not an emergency. So if we have that the background, we'll look at the options. First, A, discontinue aspirin, continue clopidogrel, and proceed with cataract surgery. That's not the correct answer. B, discontinue clopidogrel, continue aspirin, and that's also not the correct answer. C, discontinue both aspirin and clopidogrel and proceed with cataract. That would also expose the patient to a reinfarction. D, and also even the stent will also get into thrombosis. D, postpone the surgery for at least 6 months and preferably 12 months, at which the clopidogrel can be discontinued. E, I advise to perform the surgery while she is on both aspirin and clopidogrel, as she will never be able to stop either medications. That would increase the risk of bleeding. So the correct answer here is D. The surgery should be postponed since it's not an emergency. So with the background, we've stated already that percutaneous therapy of coronary disease, which the patient underwent, necessitates the need for the patient to be on the aspirin and the clopidogrel therapy for that long of 6 months. So that's and then the eye cataract is not. So the answer here is D. 137. Mrs. Constance is a 65-year-old recently retired librarian with a history of hypertension. After retirement, she began an exercise walking program, but noted that she was markedly short of breath and had moderate chest pressure after only 2 to 3 blocks as breathlessness on moderate exertion. She presented to your office 2 weeks ago, given your concern that her symptoms were due to coronary artery disease. You referred her to a cardiologist for diagnostic coronary angiography. This was performed 1 week ago and revealed high-grade focal stenosis of the proximal left anterior descending artery, left circumflex artery, and right coronary artery. Other than these lesions, she did not have flow-limiting disease. The cardiologist did not perform a PCI and recommended a conversation with the local cardiothoracic surgeon to consider coronary artery bypass grafting. Ms. Constance now returns to your clinic for advice. You have the cardiologist and the cardiothoracic surgeon on conference call during the meeting. When counseling Mrs. Constance about which revascularization strategy to choose, which of the following statements is true? A, TABH has a lower mortality rate at 1 year than BCI for patients like Ms. Costa. That's not true. I think they both have equal risk and mortality improvement also. B, at 1 year, patients like Ms. Constance undergoing CABG have a higher risk of needing other procedures for revascularization than patients undergoing PCI. That's not also true. C, PCI carries a higher risk of stroke than coronary artery bypass grafting. No, that's not also true. D, the characteristics of coronary anatomy and the cardiologist's anticipation of success with PCI should factor into the decision. Let's leave that. E, PCI has a lower rate of myocardial infarction at 1 year than CABG for patients like Ms. Constance. I think this one we may, well, A, B, C are not correct, then we're left with D and E. PCI has a lower rate of MOI at 1 year than CABG for patients like, okay, that's not also true. I think the correct answer here is D. The characteristics of coronary anatomy and the cardiologist's anticipation of success with PCI should factor into the decision. Okay, someone has asked answer to question 134. Question 134, the correct answer is D, was to proceed with urgent PCI intervention for that patient. All right, question 138. Mr. Gruzing presents to your cardiology practice for shortness of breath and mild chest pressure with exertion. After a careful history and physical examination and a thorough discussion with the patient of the risks and benefits, you refer him for the 99 scan, which reveals infraopical posterior ischemia. You probably refer him to your colleague for coronary angiography. At angio, he is found to have a left dominant system with a totally occluded left circumference artery. The distal left circumference artery is filled via collaterals from the left anterior descending artery. The interventional cardiologist is quite skilled, but she's unable to cross the total occlusion in the left circumflex using a hydrophilic wire and the antegrade approach. Which of the following statements regarding the intervention of this chronic total occlusion is true? This is a little bit highly technical, and our perfusion specialists need a little bit of assistance to go through this. So let me read option A. If the chronic total occlusion cannot be crossed with any wire in the antegrade approach, the operator should always abandon the percutaneous repair and consider referral for coronary bypass surgery. Let's go through again. B, attempting to assess the total chronic total occlusion via a retrograde approach through a collateral vessel is an option when attempting PCI. Okay, this looks C, although the presence of the chronic total occlusion is associated with a higher mortality rate, successful PCI of the chronic total occlusion has never been shown to lower this mortality rates. That's not also true. The coronary artery bypass surgery of the CTO is rarely successful due to the arthritic nature of the vessel distal to the chronically occluded segment. That's not also true. E, in studies, successful revascularization of the chronic total coronary occlusion is associated with symptom relief, but no improvement in left ventricular function. I think the A, C, D, E looks quite for the correct answer. The correct option that is quite correct here is B. Attempting to assess the chronic total occlusion via a retrograde approach through a collateral vessel is an option when attempting a percutaneous revascularization. So this is the correct answer here. Is an interventional skill procedure. Question 139. A 67-year-old former truck driver underwent poor vessel cabbage 12 years earlier with with a left internal mammary artery, graft to the with a left internal mammary artery graft to the left anterior descending artery, and 3 saphenous vein grafts to the first diagonal, first obtuse marginal, and right posterior descending arteries. At your visit with him today, he reports approximately 1 month of accelerating chest pain and shortness of breath with decreasing amount of exertion. You refer him for coronary angiography, which reveals significant stenosis in the body of the great saphenous vein grafts, to the first obtuse marginal branch. Which of the following statements is true? A, graft failure of the saphenous vein graft is almost always from thrombosis, embolized from the aortic anastomosis site. B, PCI to this saphenous vein graft will require deployment of a distal protective device. C, PCI on a saphenous vein graft is too risky to warrant proceeding. Aggressive medical management with anti-angina therapy should be pursued. This is also wrong. D, the risk of PCI to a saphenous vein graft is identical to the native vessel PCI. This is also not correct. E, venous and artificial graft condies for SVG and Lima graft have identical patency rates over the first 5 years following bypass graft. No, the internal mammary artery graft has high patency rate than the saphenous vein graft. This is a vein, this is an artery. So of course, what happens with SVG is arterialization. So that arterialization may also fail. Arterialization may also fail to be complete. So option E, D, C are wrong here. So let's look at A and B again. Graft failure of the SVG is almost always from thrombus embolized from the aortic anastomosis site. So PCI to this saphenous vein graft will require deployment of a distal protective device. Okay. B apparently is again, just as I said, I didn't get to read, but is the answer, is the correct option and the correct answer from the explanation they had already given. Usually, the saphenous vein grafts have a failure rate of up to 20% after 1 year and as high as 50% by 5 years. It's also noted that this is much higher than the failure rate of arterial conduits, like the left internal mammary artery. Now, venous graft failure after 1 year results from intimal hyperplasia and arteriosclerosis, rarely from embolization. Saphenous vein graft is associated with distal embolization of arteriosclerotic debris and microthrombi, leading to microvascular occlusion. So let's go to question 140. Mrs. Edward is an 87-year-old woman with a history of extensive tobacco abuse and resultant COPD with a forced expiratory volume in 1 second of 0.76 liter, poorly controlled diabetes, and stage 3 CKD. She was previously your patient, but has not followed up with you for the preceding 8 years. However, she comes to your clinic today complaining of chest pressure with exertion, leg swelling, shortness of breath, and accelerating fatigue with even minimal exertion. On examination, you quickly note a harsh, late-speaking systolic murmur at the right upper sternal border, radiating to the carotid arteries and with a musical quality at the apex. You cannot appreciate a second heart sound, and the carotid impulse are muted and arrives late compared to the PMI on palpation. That's the point of maximal impulse on palpation. You suspect severe aortic stenosis, and indeed, an echocardiogram later that day confirms aortic stenosis with a valve area of 0.59 cubic cm, cm squared. You refer Mrs. Edwards to a cardiothoracic surgeon who informs you that Ms. Edwards is much too high risk for a surgical aortic valve replacement, citing a higher than 15% risk of in-hospital mortality. You are due to see Ms. Edwards tomorrow. Which of the following statements to her would be reasonable? A. For this condition, medications have been shown to reduce the risk of mortality. B. It is okay that you are not a surgical candidate. Your condition carries a low risk of 1 and 5 years mortality, and we can control your symptoms with medications. C. Percutaneous aortic balloon valvotomy is a good non-surgical treatment option and has been found to have excellent short and long-term outcome. Well, that would have been applicable if this patient needed it as emergency and then was also in hemodynamic compromise. D, since you are not a surgical candidate, no other procedure exists for aortic valve replacement for you. We should consider hospice option. This is also not correct. E, we should consider referring you for further testing to see if you're a candidate for transcatheter aortic valve replacement. I think this is the correct option here. Answer number E. So option A, B, C, D are wrong. So this patient should be walked up and prepared for a transcatheter aortic valve replacement. Thank you.
Sorry, Molade. All right, Ade Anju, Chief Ade Anju.
Yes, we are here.
I think we have stopped.
Thank you so much, Chief Examiner. Well, this is 12:28 a.m. I don't know whether there are contributions or additions to what has been said so far. In Dr. Ozuke's word, silence means consent. So that's no contribution. So we just have 10 more questions more. Chief Oyebuze, any comments, sir?
No.
Okay. Thank you, sir. Dr. Philomena, are you still there? Dr. Philomena. Okay. Chief Etube, please, can we just go to 90? I think that should be 91 to 100.
Yeah, I actually need some time. I've been asking somebody to take over the share. I can't, I need some time, 5-10 minutes.
Okay. Please, can any other person help us share? Maybe 5-10 minutes. Wow. And we're almost done with this book. Who else can help us share? Chief Sawa, can you help us share? Is it possible? And maybe if you put it at 91, 92. Okay. Question 91 to okay, Chiefs. So Dr. Philomena, I'm not sure that she's close to her device. So Chiefs, as agreed yesterday, we are just going to try and finish the 10 remaining questions in Harrison. Well, we will have to all do it together. Okay. Dr. Etube. Chief Etube. Okay, must have stepped away.
Hello? Yeah,
Okay.
hello.
Yes. You still want to step away, right?
Yeah, if there's somebody that can share, I need to grab something.
Yes, Dr. Sawa is to share. So Dr.
Okay.
Sawa will share. Yes. Thank you. Chief Sawa, over to you, sir. Man. Dr. Ruki, how you doing, ma? Oh, Jesus. Okay.
Are we doing 91 to 100?
Yes, 91 to 100. But I don't know if anybody has been able to, if anyone has gone through it. I've been calling the person that's supposed to take it, but possibly she's not close to her device. Those are the remaining 10 questions in Harrison. I think we should just try and finish it up. So I will read and try and attempt the question, but I think we should all do it together. So question 91. Question 91 says, you are evaluating a 65-year-old man who has a 15-year history of non-ischemic cardiomyopathy with a dilated left ventricle and an ejection fraction of is that 15%? Yes. Yearly echocardiogram over the past 5 years have shown severe mitral regurgitation. On optimal medical therapy, the patient has NYHA class 2 symptoms. Today, he specifically asks whether his valve should be fixed in order to improve his survival. You should tell him, okay, mitral regurgitation. You should tell him option A, if you were to have high pulmonary artery pressure or develop new atrial fibrillation, we will move forward with valve repair. Option P, in patients like you, valve repair has never been shown to improve survival. Option C, we should consider valve surgery only if repair is possible. Replacement should not improve your survival. Option D, valve surgical methods have not shown survival benefit. Percutaneous mitral valve repair has been shown to reduce mortality in patients like you. Option E, yes, your valve should have been fixed years ago. Okay, so looking at all the options and the clinical scenario, I would think that the mitral regurgitation that these patients have had over the last 5 years that have been severe will have been as a result of the non-ischemic cardiomyopathy. So it might not have been a primary valvular is it disease now that I want to say in this patient. So, and with the question that they're asking, that what should we tell him? I don't think that if there will have been a valve repair, I don't think that they should wait till there is pulmonary hypertension or new atrial fibrillation before they should do a valve repair. B, in patients like a valve repair has never been shown to improve survival. Well, in option B2 is looking like a study question. I mean, sorry, what we call it now? A study question. What do they call it now? Like a trial question. So, of course, the patient with non-ischemic cardiomyopathy and dilated left ventricle, I'm not sure. I can't remember there have been studies that have shown whether repairing or reducing the the annular ring or whatever of the mitral valve will reduce the severe MR. So I'm not sure of that too. Option C looks wrong, so I'm not going to pick that too. Option D, I'm not sure. Option E is actually wrong. They wouldn't have said that. So I have between option B and D to choose from, which I'm not sure which one is actually the answer. So Chiefs,
Option B is.
Okay, why?
If we go through the pathology or pathophysiology of DCM, is actually the increased left ventricular end diastolic volume, or that would eccentric hypertrophy should most likely be responsible for the regurgitation, mitral regurgitation the patient is having. So even if you do surgery for that patient, most likely the regurgitation will continue. So that's why option B, in patients like you, valve repair has never been shown to improve survival.
Okay, but Chiefs, are there studies that have proven that? I understand from the pathophysiology and from the etiology perspective. But are there studies that have shown anything like that?
I'm not aware. Even in the answer, they didn't mention any study.
Okay, sir. Okay, sir. So the answer here is option B. Thank you, sir. Based on etiology and pathophysiology of the MR. Okay. So question 92. Chief Sawa. Thank you. Yeah, question 92. You're performing a right and left heart catheterization on a patient with stenosis involving two valves. Which two valves are involved based on the pressure reading? Right atrium 15 millimeter of mercury, right ventricle 25/6 millimeter of mercury, pulmonary artery 25/12 millimeter of mercury, pulmonary arterial wedge pressure 12 millimeter of mercury, left ventricle 105/6 millimeter of mercury, and then the aorta 105/75 millimeter of mercury. So they want us to be able to choose the valve that had an issue here. There are pressures during hemodynamics. There are normal pressures in the chambers of the heart. And I think for the aorta, I can't remember what the figures were, but for the aorta, is between 100 to 140 over diastolic, or 60 to 90. In the left ventricle, I think it's still, I stand to be corrected, I may not remember all the values well. In the left ventricle, I think the systolic is between the 100, maybe 60 to 100, then the diastolic is something to 90. I can't remember very well. So we need somebody that can remember to actually answer this question. Or we can just look at the answer. Okay.
The left ventricle is 100.
Is what? Is 100, right?
Yes, it's 100. Yeah, the left ventricle is around 100.
Okay.
And you said it was is around the 100 to the 120/60 for the Utah.
Okay.
And then the pulmonary artery pressure, capillary wedge pressure is usually less than or equal to 12.
Okay. Which
And
one is it? Okay.
Yeah, the pulmonary artery wedge pressure is less than or equal to 12, but here is 12. So which appears to be around the figure. And the left ventricle, we are getting 105/6. Usually the diastolic is about 5. So it appears like it's around it is normal. Then the aorta appears also normal.
Yes.
Pulmonary artery is
I think
less
this is a
than.
technical question. We can just read the answer and get it correct.
But we are supposed to know the pressures too. I know one is 0 to 4, 0 to 8.
If we're able to pick the abnormal ones, then maybe we can reason it from there. Because the mean pulmonary arterial pressure is less than 25. So the pulmonary artery systole is 15 to 25. And diastole is 6 to 12. So the pulmonary artery is correct in the diagram that we are given. Systolic is 15 to 25. And diastole is 6 to 12 for the pulmonary artery. So we have 25, which is correct. We have 12 for diastole, which is correct, because 6 to 12, 15 to 25. And we said the pulmonary artery wedge pressure is less than or equal to 12. That's also correct. Then the left ventricle the left ventricle is around 105, so 105.6 is marginal. It's not so significant. Then the aorta, we are looking at somewhere 100, 120, 60, 80. So it's 75, 105 is within range. The right ventricle systole is 20. The right ventricle systole is 15. But here we have a right ventricle of 25. It's about 10. So that's increased.
That's high. Okay.
And that's high. And diastole is 10 for the right ventricle. 0 to 10. So this one is 6. So yeah, there's a systolic pressure in the right ventricle. That's a big increase. Then the right atrium is 0 to 5. That's also 15. That's also increased. So we have pressure in the right ventricle. Systolic pressure is high in the right ventricle. And then there's increased right atrial pressure, which is 5.
Yes. Okay.
So the 15 is more than so it's about 10 above it. In the right ventricle, there's a systolic pressure of 25, is 10 above it. So 15 to 25. So the right atrial pressure is 10 above it. Right ventricle appears to be normal because we said it's 15 to 25. The systole, and diastole is 5 to 10. Systole is 25, so it's within range for the right ventricle, and the diastole is 6, it's within range of 0 to 10. So the increment is typically in the right atrium, which is 15 instead of 0 to 5.
Okay.
If you have increased right atrial pressure,
okay,
then it's most likely we may be having issues with the tricuspid. It has to be in the picture, right?
Yeah.
And then anything that will give pressure back to the right side of the heart. In terms of stenosis, you see that tricuspid, or there is
there's a backflow from the left or from the
the
pulmonary.
left. The only thing is that I'm trying to get which part to the left. The right atrial pressure, obviously, that one we know is high.
I think it was the LA pressure, but it's the same thing as the pulmonary arterial wedge pressure, right?
No, yeah, so they give the pulmonary arterial wedge pressure, which is 12. And then the 12 appears to be, is less than or equal to 12, so.
What about the LA pressure?
The left atrium.
It's the same thing as the pulmonary arterial.
Yes, there's the same. Yeah, it's the same thing as the pulmonary arterial wedge pressure. So we have to use the 12. The only thing is what I'm not sure. The only thing is if there is anything, the right ventricle is 25, 6, which appears to be within range. So the answer will be between. So it can be the aorta because the aortic pressures appears to be normal. If there's aortic stenosis, because the question wants us to choose stenosis, right? It says stenosis.
Yes.
So if there is stenosis, then clearly the pressure in the aorta would have probably. In stenosis, what happens to the pressure in the aorta? It decreases, right? The gradient is big, but the pressure will go down or it will go up.
The pressure will go. I think it will go up. The aorta. The pressure in the aorta is the highest. Maybe we should just read the answer.
Let me just take these 2 lines from the answer that will just support what you read. In the presence of tricuspid stenosis, flow is decreased to the pulmonary vasculature and the left heart, thus blunting the hemodynamic effects of even severe mitral stenosis. Now, grading the severity of mitral stenosis in this setting is quite difficult. Finally, this miss of valvular disease is essentially diagnostic or rheumatic disease Now, importantly again, the tricuspid valve is never involved alone and is always affected only if the mitral is also involved. So with having gotten the mitral, that the mitral is involved, and with this background, we should quickly know that the the mitral valve is involved at this level, because the tricuspid is never ever affected alone in the background of rheumatic heart disease and comes with mitral valve involvement. So the answer we are now left with is D.
That's D. Yes.
And I think it mentioned here that in the presence of tricuspid stenosis, flow is decreased to the pulmonary vasculature and
Okay.
left heart, thus blunting the hemodynamic effect of even severe mitral stenosis.
Yes.
So I'm sure that's why we are not getting the increased capillary wedge pressure,
Exactly.
right?
Yes.
Because the pulmonary arterial wedge pressure is normal, is 12. So we are not getting it even in the presence of mitral stenosis because of the decreased blood flow to the pulmonary vasculature because of the tricuspid stenosis. Yes.
Yeah, beautiful. Thank you so much. It looks simple now. Thank you. So
Even
the
though
correct
even though we may need to review their data, because I know if not now, we've treated tricuspid rheumatic heart disease for more than 3 times in drug abuse, and they all came alone. Mitral was never involved.
I think for
Yeah.
it's different. For
Please,
high
come
heat,
on.
for high
In,
heat,
in rheumatic heart disease, the ones we treated, was it rheumatic heart disease or other condition? Because I remember one of the ones we read that has to do with rheumatic heart disease also stated that mitral is not involved alone.
yeah, I think that would have been drug, or maybe right-sided IE or thereabout.
Yes, right-sided IE.
Yeah.
The other one was repeated. The other one was just fresh right-sided IE.
Okay. Permission to continue.
Right on, please.
Thank you, sir. Before I slip off, Chief Sawa, sir. Chief Sawa, question 93.
Yes, sleeping happily. Yeah, thank you, Sarah.
Okay, question 93. You're evaluating a 50-year-old woman with idiopathic pulmonary arterial hypertension. Her last TTH noted severe tricuspid regurgitation in addition to a dilated hypokinetic right ventricle and estimated pulmonary arterial systolic pressure exceeding 70 millimeters of mercury. So she has pulmonary hypertension. On your exam, she has lower extremity edema, hepatomegaly with a pulsatile liver, jugular venous pulse elevated to the mandible with marked CV waves, and a prominent Y descent, and an RVE. She reports breathlessness with moderate exertion. What is the best treatment for a severe tricuspid regurgitation? Okay, so option A, diuretic and salt restriction accompanied by medical therapy targeting elevated pulmonary arterial pressures. Option B, percutaneous balloon valvotomy. Option C, percutaneous tricuspid valve repair. Option D, surgical mitral valve replacement. Option E, surgical tricuspid valve repair. So I think the most reasonable answer here is option A. The woman is congested. She has elevated systolic, elevated right ventricular systolic pressure that is high. So even if you want to go for surgery or whatever, it is still good that you try and decongest her, give sildenafil or whatever you want to give to reduce the pressures, re-echo her to see and ascertain the level of the regurgitation and see if she can then thereafter go for surgery. Although this idiopathic pulmonary arterial hypertension is always difficult to manage. So I think the correct option here, the most likely will be option A.
Yes, so they are saying that it's hypokinetic right ventricle.
Already.
So if it's
Okay.
hypokinetic right ventricle, it means that it's most likely that there may be a functional component to it, the TR.
Yeah.
And then there is evidence of pulmonary hypertension. So you wouldn't want to do just an isolated repair of the TR unless maybe probably you are repairing other valves as well. But you do a balloon valvulotomy if it's tricuspid stenosis. But there's a regurgitation, so obviously that is a force. And per reading, they said there is no clinical thing like percutaneous tricuspid valve repair. They don't have it yet.
Okay.
Then the surgical mitral valve replacement, you are talking about the TR. So you are talking about a TR, so that would obviously not be the best. I don't know if did he mention anything about the mitral valve?
Yes, it's surgical mitral valve replacement. That's option D.
No, but like in the question, was there anything about the mitral valve?
No. It's just tricuspid valve, features of right-sided heart failure,
Okay.
and elevated right pressures.
Okay, so and then surgical tricuspid valve repair, you wouldn't want to do isolated tricuspid valve repair because of also the pulmonary hypertension and all that. So the first thing to do is to do the
Hello.
So the answer is A.
Okay, thank you.
Yeah, the answer is A. This is one of the cases you optimize first before you do a repair. So both the pulmonary hypertension and heart failure needs to be controlled.
Okay. So question 94. Chief Surgeon, question 94. Okay. 94. You're seeing a 21-year-old woman for the first time today in the primary care clinic. She has never seen a physician before because her parents did not believe in Western medicine. On history, she stated that she feels tired occasionally and feels like she could not quite keep up with her peers in college physical education classes. On examination, you notice systolic murmur in the left second interspace preceded by a presystolic click. Transthoracic echocardiogram confirms the presence of pulmonic stenosis with a peak gradient of 60 mm of mercury and doming of the pulmonic valve without any pulmonic regurgitation. What's the best treatment option? So this pulmonic stenosis, all right. Option A, diuretic and salt restriction. Option B, no therapy needed. Option C, percutaneous balloon valvotomy. Option D, percutaneous pulmonic valve replacement. Option E, surgical pulmonic valve replacement. This patient is symptomatic of pulmonic stenosis. I think somebody was also talking about pulmonic stenosis for us recently. So diuretic and salt restriction, there's no indication for that in this patient. Of course, she needs therapy because she's having some limitation. So for management of pulmonic stenosis, if I recollect what we were taught recently, I think that we can do a percutaneous balloon valvotomy. But of course, if there are presence of other valvular diseases and not just isolated pulmonic stenosis. Maybe that's when we can now um go in and do a surgical approach. Like Dr. wanted to talk earlier about surgical approaching, that's an aortic valve. But maybe if you have like two or three valves affected, maybe we can do a surgical approach. We are just told now that there is no. Okay, that was for tricuspid valve. So I'm not sure about D, but I would have gone for C.
Yeah,
I
so
will go.
it's most likely C.
Mm-hmm.
So they don't really do percutaneous pulmonary valve replacement.
Okay.
Yeah, so if you do it, basically you do it like the Ross procedure in aortic valve. But there's limited data on that, and that's just an adoption. So everything on it is basically being done based upon guidelines on surgical management of aortic valve replacement surgically for pulmonary stenosis. So the percutaneous balloon valvotomy is probably the right answer.
Okay.
We came across this question in um the book we first written, Brownwood, yes. Yeah, we came across in Brownwood. The treatment of choice for pulmonic stenosis is the percutaneous balloon valvotomy. That's the treatment of choice. And of course, it's also been noted that for such patients, provided that they don't have, there is less than moderate pulmonic regurgitation. Of course, that is also recommended for pulmonic stenosis. So such patients is the treatment of choice. You're also trying to ensure that they don't have regurgitation. I think what you read also mentioned that the patient was not having regurgitation. But let me just take a reading from this. Say the pulmonic balloon valvotomy is recommended for symptomatic patients with a doomed valve and a peak gradient more than 50 millimeter mercury or mean gradient more than 30 millimeter mercury, and for asymptomatic patients with a peak gradient more than 60 or mean gradient more than 40. Surgery may be required when the valve is dysplastic, as seen in Noonan syndrome or other syndrome. So once the pressure gradient is more than 50 for symptomatic or more than 60 for asymptomatic.
Okay. More than 50 for symptomatic. Right?
Yes, sir.
All right, sir. Thank you very much, sir. So the answer here is C, right?
It's C, yes, sir.
Okay, thank you. Question 95.
So let's just note, once we see pulmonic stenosis, the choice treatment or the treatment of choice is percutaneous balloon valvotomy.
Yes, sir. Yes, sir. Noted, sir. So question 95. You are taking care of a 77-year-old patient with severe aortic stenosis in the cardiac intensive care unit. Surgical aortic valve replacement is planned for tomorrow. However, suddenly he became severely short of breath and manifest signs of acute pulmonary edema. On auscultation, we can now appreciate a soft, short apical systolic murmur, in addition to his previously appreciated murmur of aortic stenosis that was not present previously. It's over that he has suffered a ruptured mitral valve chordae and now has severe acute mitral regurgitation. Which of the following parameters will likely increase due to his new severe mitral regurgitation? So they said A, aortic valve gradient, B, calculated aortic valve area, C, effective stroke volume, D, ejection fraction, E, left ventricular afterload. Okay, So for this patient that suddenly have acute MR, so what will happen in MR? There will be
So
back.
it most likely will be D,
Yeah, okay.
maybe the ejection fraction, because once there is an obstruction in the left ventricular flow tract, the aortic stenosis, that would naturally cause a reduction in the overall resultant ejection fraction over time. But once you have a mitral regurgitation, it means that subsequently the pressure gradient across the aortic valve will preferentially decrease because of the back opening, which is the mitral regurgitation. So once the pressure gradient decreases in that context, I'm confused.
I think it's because thank you for starting up the discussion. Okay, I get where you are going. You are going to aortic regurgitation rather than aortic stenosis, right? That's where you are going to. I'm not also sure. What I can remember is that if there is MR, there will be backflow of blood. Then that's why the patients have pulmonary edema likely. But while ejection fraction will be increased here, I can't really say for now. I can't really say because his MR is going back. Let's say it's a forward flow going forward now. We say okay that that the end diastolic will be increased and then the blood that is being effectively taken out will also increase. So I'm not sure. Maybe we should read the answer, or if anybody have a
Let me read the distance. You said this patient is in a precarious situation and likely will require emergent surgical intervention to survive because acute MR from such a rupture is a medical emergency. The combination of severe obstruction to LV outflow, that's severe AS, and acute severe regurgitant mitral valve disorder will inevitably lead to intractable pulmonary edema and cardiogenic shock unless both structural abnormalities are corrected. At the advent of severe mitral regurgitation, the LV will be more effectively unloaded because now it can eject not only against the stenosed aortic valve, but also into the relatively low pressure left atrium, and thus afterload would decline. Likewise, with more of the stroke volume going ineffectively into the left atrium, the effective stroke volume, total stroke volume, that's regurgitant volume, would decline. The aortic valve gradient would decline merely because there is less volume going across the aortic valve with each contraction. Likewise, because both the catheter-derived and the echocardiography-derived calculations of aortic valve area are dependent on the gradient for calculation, they will decline. Ejection fraction, however, will increase as the LV will be better able to contract in the state of relatively lower afterload. So I think that's what I was trying to, but I got confused. So that's what they said. So this highlights a misconception that higher ejection fraction is always better. LV ejection fraction is highly dependent not only on the contractile state of the ventricle, but also on its afterload state. So then what would be the answer?
You said D now.
Yeah, but they also mention afterload in their explanation, so I don't know.
D would be the answer, but it will not be an effective ejection fraction.
Okay.
Okay. And I think that because it's also an acute thing. So if the load in the ventricle is also increased because it's acute. So because it's acute, so it's likely that the ejection fraction will be high, but like they said, it's not effective. I don't know what is being pushed out from the left ventricle will be much. let me use a layman's language. But
You
then
see that the
Yeah,
left brain.
in the layman's language, with the regurgitation, the left ventricle is unloaded, and
yeah,
with that unloading, it will begin to have a higher force of contraction, and that's why they say the ejection fraction, however, will increase as left ventricle will be better able to contract in the state of relatively lower afterload.
yes, yes, but it doesn't mean that it will increase the overall blood circulation. It's okay. The answer is D.
Answer is D. 96.
Okay, so should I continue? Question 96. Mr. Millsap is one of your long-standing clinic patients who has a history of rheumatic heart disease. His last echocardiogram noted a mean mitral valve gradient of 11 millimeters of mercury with a calculated valve area of 1.3 centimeters squared at a heart rate of 60 beats per minute. He presents today complaining of worsening shortness of breath, and his ECG shows atrial fibrillation at a rate of 60 beats per minute. He has never had any bleeding episode and had normal hematologic counts on his last check 2 weeks earlier. Which of the following options for thromboembolic prophylaxis is appropriate? Okay.
So it's my
Now,
trust in the valvular effect.
yeah, so if it's valvular from our Invictus trial and all those trials, so it's
It's
not
D.
all, it's D. It's not all this new or anticoagulant, right? I think the answer
Yes.
is D. Okay.
Yes.
All of the following are risk factors for development of peripartum cardiomyopathy, except, okay, so for peripartum cardiomyopathy, advanced maternal age, everything.
That's true.
So I think the answer here, although we have different from the peace registry is supporting pramiparos, I think, but from data from high income countries, they are not supporting pramiparos unless if the first pregnancy is at an advanced maternal age. So I wrote the option that they've picked here, but I will have picked C if we are working with the other countries' data. Use of tocolytics has been implicated, twin pregnancy, malnutrition, advanced age, and some other things. So I don't know what the answer is, but I will have gone for C. Please, what's the answer, says?
It's C.
C.
All right, thank you. Question 98. But if they bring this one out again, maybe they will change the options, because in the peace registry and even in the local study, most of the patients are young, first pregnancy. That's in local studies in Nigeria.
Young and first pregnancy.
Yes.
Oh.
Yes. For us, I mean the one that was done in Ibadan, young first pregnancy, and even when they come in, maybe between 18 and 25, first pregnancy, few months after delivery or few weeks after delivery. So it's just to have it at the back of our mind. But if this question comes, I think we will still give you the answer in the book. So 98.
Sorry. So now, this occurs in the young. So what are the risk factors and what are possible excepts there?
If it's okay. It's okay. You have to tell me that what you've taken tonight, because your voice is 100% very clear. Well, some of us are feeling sleepy.
I'm distracted to halfway, so I'm up now. I'll be up till 4 a.m.
No, wala. So the things that were noted are the poor socioeconomic post socioeconomic factors, education, malnutrition, what other things? I think financial what we call it now, financial status also came in, but the most common one are the socioeconomic factors. Okay, I think financial is part of socioeconomic, malnutrition, education. I think those were the things. If Orimolade is awake, maybe she can remember the others. But those are top on the list.
All right. Thank you.
Yes. Question 98. You are evaluating a new patient in clinic. The 25-year-old patient was diagnosed with heart failure in another state and has since relocated. He has NYHA class 2 symptoms and denies angina. He presents for evaluation and management. On review of system, the patient has been wheelchair-bound for many years and has severe scoliosis. He has no family history of apical lipidemia. His physical examination is notable for bilateral lung practice, an S3 and no cyanosis. An ECG is obtained in clinic and shows tall R wave in V1 and V2 with deep QS in V5 and V6. An echocardiogram reports severe global left ventricular dysfunction with reduced ejection fraction. What is the most likely diagnosis? Option A, amyotrophic lateral sclerosis. Option B, atrial septal defects. Option C, chronic thromboembolic disease. Option D, Duchenne muscular dystrophy. Option E, ischemic cardiomyopathy. I will have gone for option D here.
So option E.
D.
D. Okay, that looks like more likely the answer, but it appears as because once there is impaired left ventricular dysfunction, CTEF is out.
Yeah.
And then we didn't see any septal defects as well. The ECG is not also too suggestive. And this 25-year-old. And ischemic cardiomyopathy is actually non-specific. I mean, these findings that they gave, I'm sure if someone even chooses ischemic cardiomyopathy, they can be right. But the thing is that they are saying that this finding is very unique for Duchenne muscular dystrophy.
Yes, I think for those muscular dystrophy, they affect the V1, V2.
Yes, they said the AML, amyotrophic the ALS, that one will cause R waves in V1 and V2, but just that this time the Q waves will be in the limb leads, the deep Q wave, not V5, V6.
Okay.
And Duchenne muscular dystrophy will be in V5, V6. The Q will be in V5, V6, but ALS will be in the limb leads, the Q. But they'll still have the R waves, the tall R waves. And the CTEF, because of the LV dysfunction, it rules it out.
Thank you so much. Because they
Sorry.
could have painted a picture of ALS too. So we should just look at the limb
Hey,
leads for the
sorry. So it's Duchenne muscular dystrophy. That is in the limb leads and V5, in the limb leads, and also V5, V6. ALS is motor neuron, so it's not part of it at all. They say ALS is motor neuron, so it doesn't involve the heart at all. So the option is D.
Sorry, will you come over that? So you're saying that in ALS there is nothing in the limb leads, right?
In the ALS, there is no involvement of the heart because it's a pure motor neuron disease, right?
Okay.
So in Duchenne's, it's R in V1 and V2, and they have deep KOS in V5 and V6, as well as the limb leads. But in this question, we only have V5, V6, then bring the limb leads.
Okay. Thank you, sir. Chief Uzuki, say something.
Exactly the same question I wanted to ask. Thank you very much.
Okay, thank you. Question 99. Chief Sawa. Chief Sawa. Thank you. Okay. Which of the following is the most common? Which of the following is the most common inheritance pattern for familial cardiomyopathies? They are common. A. Autosomal dominant driven by exon duplication. B. Autosomal dominant driven by missense mutation. C. Autosomal recessive driven by exon deletion. D. Autosomal recessive driven by exon duplication. E. X-linked driven by exon duplication. So for me, I will first cancel C, D, and E because familial is autosomal dominant. So be between A and B. I think I would have gone for B, a missense rather than a
More common, eh?
but I
Yeah,
don't
I'm
know
more
the answer.
familiar with Maze sense. Okay, so I think let me see if that's what they chose.
B, right?
Yeah, they chose B.
Yeah.
Okay, let's say they said missense mutations with amino acid substitutions are the most common in cardiomyopathy.
Okay. And if you can remember all these DNA, RNA, if you can still remember very well, ideally exons go away, the introns are retained. So the exons most, I can't remember all those things very well. All those helical structures.
Exon intron.
Yes, exon introns. So most times those if
That's
they do,
physiology and biochemistry.
yes. So if they've said intron now or something like that, maybe one would have been okay. What's happening there? But I think it's a missense.
So you use common sense here. Exon is going out. Exon is the cutoff part of the data that is
Chief
okay.
exam now. Let's do the last question now. For me, that I want to sleep. Let me go and sleep. Oh.
No, let's when we finish this one, we'll continue
But
with the other.
it's okay. It's okay. Question 100. A 45-year-old man with obesity presents to the emergency department with dyspnea, fatigue, and a nocturnal cough that has been worsening for the past several months. He denies any chest pain or pressure at rest or with exertion. On evaluation, he has evidence of cardiomegaly with a PMI. What's PMI now? An elevated feeling pressure with bilateral
Point of
Maximum
maximal
impulse.
impulse.
That's for Apex beats.
Okay.
On examination, he has evidence of cardiomegaly with a displaced point of maximal impulse, elevated and elevated jugular venous pressure. Echocardiography reveals a globally depressed left ventricular ejection fraction of 25% with a dilated left ventricle. Which of the following tests is a level 1 recommendation for further workup? Option A, cardiac MRI. Option B, coronary angiography. Option C, ESR. Option D, serum iron and transferrin saturation. Option A, thyroid stimulating hormone level. Okay. With what they've said, with the clinical picture, cardiomegaly with maybe it's something like more of like an infiltrative disease that the patient is having. If that's the case, if it's infiltrative, well, I won't know if it's hemosiderin laden. If it's hemosiderin laden, I will be thinking of option D. If it's not hemosiderin laden, I will go for cardiac MRI. So I don't know what the answer is, but maybe I'll go for more of D. A.
The answer is E.
E.
I think this is a guideline question, so sometimes
Okay.
So they said level 1. So they
What's the
so
Let's
explanation?
read it. They said all of the tests listed have a
mm,
role in some patients with newly
oh,
diagnosed cardiomyopathy. However, only a thyroid stimulating hormone level receives a level 1 recommendation from the ACC-AHA for all patients with new cardiomyopathy, because maybe possibly because of the thyroid cardiomyopathy. So all other tests listed are driven by symptoms and signs that are present. Cardiac MRI and ESR levels may help diagnose inflammation in patients who are suspected to have an acute myocarditis or infiltrative disease. Coronary angio is only recommended for patients with angina, although one must be careful to include dyspnea on exertion as an angina equivalent. Serum iron and transferrin saturation are worth checking in patients suspected of hemochromatosis. Table V100, of course, they show the table here, list test available for the initial evaluation of new cardiomyopathy and indicates which receives a level 1 recommendation for all patients.
It's so
so they
sad.
have thorough history and physical examination,
Okay.
detailed family history of alcohol, illicit drugs, all of them are level 1. Then laboratory wise, talking about ECG, chest radiograph, 2D, echo and Doppler, magnetic resonance imaging for evidence of myocardial inflammation and fibrosis. Then the chemistry, serum sodium, potassium, calcium and magnesium, creatinine and blood urea, lipid profile, TSH, that's the thyroid stimulating hormone, serum iron, transferrin saturation, urinalysis, then creatinine kinase isoforms, then cardiac troponin levels. So the only ones, all these things you can do them, they said is good. But the only one that has been marked as level 1 indication in all these lists that I mentioned is the chest radiograph, ECG, TSH, kidney function, and then
The MRI now.
let me see. The MRI, they didn't mark it. So they said all
Serum
of them.
sodium, serum potassium, calcium, magnesium.
That's serum potassium, calcium, magnesium. That one was also marked. Then the kidney function, that's the creatinine, urea. Then albumin, liver function test, all of them are part. Even lipid profile was not marked.
Lipid profile was not marked.
No, it was not marked. Yeah, TSH, thyroid function was marked. Urinalysis, urine was not marked. Creatinine kinase was not marked. Cardiac troponins was not marked. Full blood count is marked. So full blood count, BUN creatinine,
White blood cell
potassium.
differential.
ESR was not marked. Yeah, so it's basically ECG, chest radiograph, kidney function, electrolytes, potassium, calcium, magnesium, sodium. Then you have the echo, and then you have the thyroid, and then liver function test. I think essentially
why the choice of liver function test and then serum protein over lipid profile?
I don't even know. I don't know whether this is old, but this one is according to the ACC. So
yes.
I don't know.
To develop our own guideline. And they should ask us questions based on what we see in our own environment. Because if it's our own environment, TSH will not be level 1 now. I mean, we will have put
liver function test and serum albumin will not also be.
Urinalysis will have been, top.
Yeah, because you and I'm surprised.
Oh God, interesting.
Chest tester, I wonder how many that also request for it now. If do echo.
Well, some people for completeness, or if they are doing research, they still try and request for chest X-ray. Yeah. Thank you so much, everyone. Chief Examiner, over to you, sir. I said we are continuing till 4 a.m. or thereabouts. So.
Dr. Ned, you can't just someone joke again. Na joke, I joke, I beg go.
Oh, there's like joke. Oh, we have to continue.
Na joke, I joke. According to late Mr. Ibu, na joke.
God.
Can we please stop the recording, please?
Oh, God. Chief Sawa, sir, can you kindly help us stop the recording?